Dr. Lowe,
Hmm.
how are you today?
Hi, I'm good.
Excellent.
All right. So I just
Are,
wanted to
are you,
tell. Hmm?
sorry, Richard, are you hearing an echo as Dr. Lowe speaks?
Um,
Yes,
So Dr. Lowe speaks, Richard has your file and he will be the one. Richard will be the one doing your file for you.
okay. So I just wanted to tell. You're saying you're hearing an echo. Is that from my side?
I'm sorry, say that again?
Is the echo from my side?
No. You're hearing a delayed broadcast of what you were saying. Are you hearing an echo still?
No.
Okay, fine. Hello, Dr. King Robertson. Good morning. How are you? You are muted.
Hi, morning. I'm fine, thank you.
In quite a while. So as the moderator, I'm going to give you a call on the phone now.
Okay.
All right, because we go live in about 2 to 3 minutes.
Sure, no problem.
Dr. King, is your WhatsApp on? I can't. It's not appearing on my phone.
Yes, it is. You have the right number. I've been in contact even up to today with Miss Thomas, up to this morning.
All right, 1 second. Yeah, I think I have the right number. All right, I'm gonna try in
Give
1
me your
minute
number
again.
and I'll call you.
Sure. It is +597 815.
My number is
Give me
missing.
1 second. Give me a second.
Oh.
Got enough. Hi, Miguel.
Hi, good morning.
Good morning.
I, so we are letting people in now. We have about 2 minutes.
Okay, go ahead. Okay, Miguel.
Her iPad not on, Alex. She watching the TV. Or turn off the TV. Sorry, morning. If I can speak to one of the coordinators or Ms. Thomas, Dr. Grant is actually the first presenter. She says that she hasn't gotten the link.
All right, thanks. I'll resend it to her.
Thanks.
Also, Miss Thomas would send you my contact, and so you can try contacting me instead because I'm not seeing your name. So.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocherez, with our mission to provide exceptional and affordable healthcare. Apex Radiology is a clear choice for your diagnostic needs.
Mr. Leslie, you are live.
Thank you. A pleasant good morning, all. Let me take this opportunity to welcome you all to our colon cancer awareness medical symposium. My name is Michael Leslie. I am the acting executive director for the Jamaica Cancer Society. One of the mandates of the Jamaica Cancer Society is to create awareness as it relates to cancers in general. And that's why we are here this morning. We are having the symposium because, as we all are aware, March is celebrated as Colon Cancer Awareness Month. And as a cancer society, we seek to create the awareness as it relates to colon cancer. Today, we have a number of experienced and highly qualified medical personnel sharing on various topics related to colon cancer. We have on our list of presenters this morning, we have Dr. Nicole Grant. We have Dr. Dwight Lowe, Dr. Pember Peters, Dr. Karen Pemberton, Dr. Kevin Smith, Dr. Tamu Davidson, and Dr. Nadine Williams. These are our panelists this morning, highly qualified, highly experienced in the area of colon cancer. So we look forward to some great presentation this morning. I will just mention some of our sponsors this morning, because without our sponsors on board, we definitely would not have had this symposium. These are our partners, and we appreciate them. And I'll take this time to mention Apex Radiology, Pace Pharmaceuticals, Roche, Abbott Lab, and AA Lacris. These are our sponsors for this morning's symposium. So let me just take this opportunity again to welcome you all to our medical symposium this morning. And I'll now hand over to our able moderator, Dr. Christy K. King Robinson. Dr. Robinson, over to you.
Good morning. Good morning, everybody. Thank you for joining us. I am Dr. King Robinson, Krista K. King Robinson. I'm a consultant gastroenterologist, and I'm very pleased to be moderating this symposium today. When I was asked, I was pretty much over the moon because colon cancer is near and dear to my heart. And looking at the panelists that we have today, it's panning out to be an excellent morning. We will be starting with Dr. Nicole Grant Steer, and I will briefly introduce Dr. Grant Steer. She is originally from Kingston, Jamaica, and she completed her first degree in biochemistry and zoology, as well as her Bachelor of Medicine and Surgery at the University of the West Indies. She then pursued the specialty of radiology at UWI as well. And while she was a resident, she had rotations at the Weill Cornwall, New York Presbyterian, and the Yale New Haven hospitals. She has been the only full-time female radiologist at Radiology West for the past 9 years. During this time, she did formal training in virtual colonoscopy at the University of California, San Francisco, under the tutelage of radiologist Dr. Judy Lee, one of the developers of this novel technique. She is passionate about raising colorectal cancer awareness and has been integral in promoting virtual colonoscopy as a minimally invasive screening tool in the Western region. Dr. Grant is a member of the Jamaica Association of Radiologists, the Radiological Society of North America, and the American College of Radiology. At this time, it's my pleasure to allow Dr. Grant Stair to proceed with her presentation.
Hello, everyone. Firstly, I'd like to say thank you to the Jamaica Cancer Society for having me and for always facilitating these very well-needed and informative conferences. And thank you to you all for being here with us this lovely Sunday morning. I'll be presenting imaging the acute abdomen in confirmed and unsuspected colorectal carcinoma. We'll be discussing an acute abdomen, what is an acute abdomen, colorectal cancer, complications of colorectal cancer, and how it presents as an acute abdomen, the imaging modalities that are used in the investigation of these complications, and have a few case examples that we will review just to see what it looks like. The acute abdomen is a clinical condition characterized by severe abdominal pain, requiring the clinician to make an urgent therapeutic decision. Management may vary from emergency surgery to reassurance of the patient. Misdiagnosis may easily result in delayed necessary treatment or unnecessary treatment. The differential diagnoses include a wide spectrum of disorders, and they range from life-threatening diseases to benign self-limiting conditions. Colorectal cancer, as the name suggests, is cancer of the colon or rectum. Most colon cancers develop from polyps, which have a natural history of about 10 years. In Jamaica, colorectal cancer is the third leading cause of cancer-related mortality and represents 10% of all new cancer diagnoses. The risk factor for colorectal cancer increases with age. 90% of cases are diagnosed in individuals 50 years of age and older. And while the rates of colorectal cancer have been declining among adults 50 years and older, it is important to know that the incidence is increasing amongst adults that are under 50. Complications of colorectal cancer include bowel obstruction, which is the most common complication, 8 to 29% of persons. Perforation occurs in about 2 to 10% of patients with colon cancer, intussusception of lesions, and ischemic colitis. And the symptoms of these complications are non-specific and typical of your acute abdomen, abdominal pain, nausea, vomiting, etc. The range of pathologies that can produce abdominal pain, as we already discussed, is broad and necessitates an imaging approach that identifies pathology in many different organ systems. The American College of Radiology appropriateness criteria gives us a guide of the better modalities to use. As you see here, CT abdomen and pelvis, which is the workhorse for most institutions, is number one on that list. But other modalities that we can use and have used, such as ultrasound, X-ray, and MRI, are also usually appropriate and may be appropriate in some cases. And as we said, the imaging modalities that we'll be discussing, X-ray, ultrasound, and MRI, and we'll save CT for last. Studies have shown a limited role in the evaluation of non-traumatic acute abdominal pain in adults for X-rays. It can be useful in the setting of bowel obstruction and constipation, but it's recommended only if a positive result would prevent subsequent imaging. It can also show pneumoperitoneum. And I know we commonly use X-rays as our first line imaging when we suspect bowel obstruction, looking for, those fluid levels and so on. But it's important to know that it does not exclude an ileus. An ileus may not be appreciated on abdominal film if the loops are filled with fluid with no intraluminal air. And this is an example of that very same thing. The plain X-ray shows, I hope you see it very well here. The plain X-ray shows relatively a normal abdominal X-ray, no dilated bowel loops identified. However, the CT demonstrated that the small bowel loops were fluid filled. Ultrasound does not require ionizing radiation. It allows precise correlation of the ultrasound findings with the area of maximum tenderness and with a palpable mass. Mobile and flexible, that is ultrasound. It can be used in the emergency room, it can be used in ICU, it can be used in OT. Ultrasound guided puncture is a safe and rapid way to determine if intra-abdominal fluid is blood, pus, bile, amylase, etc. And this is just a picture showing a quick demonstration of quickly in the ER or in any setting that your ultrasound can be used to tap fluid that's in the abdomen and get some information about what is actually present. These images demonstrate the appearance of free fluid and free air on ultrasound. Here you can see this dark area is a representative of a small amount of free fluid. This bright line following down in between is the appearance of free air within the abdomen, and it is also demonstrated here. Ultrasound can also demonstrate bowel obstruction in some severe cases. The patient's body habitus permit. It can be shown. This is an example of dilated fluid-filled small bowel loops, and you can see that the material and fluid within is moving sluggishly in keeping with obstruction. These images, I know it's flashing a little bit on your side, demonstrates large bowel also obstructed and fluid filled. Not often, but in some cases, the cancer of the colon cancer can actually be seen on our ultrasound images. And this is an example of same. This is a asymmetrical thickening of the cecum in keeping with a cecal carcinoma. MRI. I know many of you are going to be like, MRI, who uses MRI for acute abdominal pain? It can be used. MRI has longer acquisition times relative to CT, yes. However, with improvements in technology, tailored abdominal protocols, they can be performed in 10 minutes or less in some settings. One prospective study looking at the use of non-contrast MRI in 468 patients with acute abdominal pain with an image acquisition time of under 2 minutes showed an overall accuracy of 99% in diagnosing diseases, including acute bowel inflammation and obstruction. Given its accuracy for a range of intra-abdominal pathologies, as well as the feasibility of distinguishing infected from non-infected fluid, MRI may be used as an alternative to CT. It should be noted that, in practice, the feasibility of MRI for acute abdominal pain will rely on institutional expertise, availability, and adoption of protocols that are aimed at rapid acquisition and multi-organ assessment. And of course, we have to bear in mind economics of the patients as well. Now, CT, our workhorse, is the most common imaging study ordered through the emergency department. And it has its advantages over ultrasound. Ultrasound is more affordable, but CT is extremely fast, and its time burden is often less than that of an ultrasound examination. It's not disturbed by gas and bone, while obesity is even an advantage, whereas in ultrasound, obesity is a disadvantage. It is more accurate, better sensitivity, better specificity, and it is not operator dependent. The protocol used for CT in general, a single-phase IV contrast-enhanced examination is performed. Some institutions no longer routinely use oral contrast because of the associated delay in management of the patient, getting them through the emergency department, and they wait, with the diagnostic advantage. Positive oral contrast may help improve confidence in identifying bowel-related pathology. However, advances in CT technology with multiplanar reformations can also improve diagnostic confidence. These studies of note are non-CT colonography abdominopelvic CTs, and subsequently they lack colonic insufflation, reduction of the fecal material, and fecal tagging, all of which limits the visibility of possible tumors in the colon. So what are we expecting to see in patients presenting with acute abdominal pain and they're known to have colorectal cancer. Possibilities include dilated bowel, free fluid, free air collection, intussusception. What you would be looking for in any patient presenting with acute abdominal pain in order to ensure that we've adequately evaluated the bowel. We look for wall thickening. Well, along with what's already stated, the dilated bowel and free fluid and so on, we also look for wall thickening, fat stranding, vascular engorgement, stenosis, and lymphadenopathy. Pitfalls for the non-CT colonography abdominopelvic CT include focal pericolic vascularity, fat stranding, local regional adenopathy may also be seen in other inflammatory bowel conditions such as diverticulitis, and therefore are not specific. Bowel wall thickening proximal to an obstructing colorectal cancer has been shown to occur in 1 to 7% of patients with partial or complete bowel obstruction, representing obstructive colitis that is postulated to be due to bowel wall ischemia. Partial volume effect of colonic hostrations on axial images can mimic colonic wall thickening. Conversely, such tumors may be mistaken for colonic hostrations. However, it's important to note that coronal reformations of images are often useful in distinguishing between hostrations and colon wall thickening. Many CT findings of malignant tumors overlap with benign entities, which can present a diagnostic challenge. Colon cancer is undetected in approximately 20% of abdominal CT examinations in patients subsequently proven to have colon cancer at colonoscopy. The absence of fat stranding, vascular engorgement, or lymphadenopathy, and an average tumor length of 3.3 centimeters are contributing factors to the failure of detection. So let's look at some cases now, and we'll see what we see in these complications. This is an example of a patient with obstruction. There is a short segment of circumferential tumor of the sigmoid colon. And in our coronal images, we see here that there is dilated, distended, fecal-laden large bowel. Another case of obstruction, an 80-year-old patient presented with abdominal pain and distension. On CT, she was found to have small bowel obstruction, as you can see here, but she was also found to have a small mass in the region of the ileocecal valve as the cause of her obstruction. Another case of obstruction, a 75-year-old woman with closed loop obstruction, secondary to an adenocarcinoma of the ascending colon here. She has a competent ileocecal valve. And subsequently, 2 days post her CT, she had perforation due to the closed loop obstruction, ended up with a right hemicolectomy. Perforation, one of our complications. In this patient, a 61-year-old patient, history of umbilical hernia, presented with periumbilical pain, thought to be an incarcerated hernia. On CT, found to have a perforated adenocarcinoma of the transverse colon, which had herniated through the abdominal wall. This patient, a 82-year-old female patient, presenting with right abdominal pain, tenderness, found to have a heterogeneous mass of the cecum here. And this is also demonstrated on the coronal, on the sagittal images, oblique images. But if you notice anteriorly, there is a small collection here. And we know it's a small collection as opposed to free fluid because there's enhancement, thin enhancement of its walls. Intussusception. This patient had intussusception secondary to adenocarcinoma of the sigmoid colon. And it is a subtle mass, just showing enhancement of the walls, and it is herniating into the rest of the colon. This is a colocolic intussusception. Another case of intussusception secondary to a cecal mass, tumor here on your sagittal images, colocolic intussusception. There are some not so common causes of acute abdomen and colorectal cancer, for example, hepatic abscesses. Multiple case reports have shown that liver abscess is also associated with various colonic diseases such as colonic diverticulitis, inflammatory bowel disease, and even colorectal cancer. From 1960 to 2011, a total of 96 documented cases of colorectal cancer-related cryptogenic liver abscesses were reported worldwide in the Eastern Asian countries. The numbers have increased by 2 times in the past few decades. Destruction of the colonic mucosal barrier and bacterial translocation into the portal system with hematogenous spread to the liver have been postulated. The male gender is more affected, mean age of patients being 64 years. A high percentage of these patients have diabetes and Klebsiella pneumoniae of colonic origin. The most common involved segment is the sigmoid colon and the rectum. And this is a patient that presented, once again, acute abdominal pain, found to have a hepatic abscess. At the time, the CT demonstrated a soft tissue density in the region of the cecum, but it was initially thought to be, collapsed segment of bowel. When the patient returned for her follow-up post-treatment of her hepatic abscess scan, this lesion was found to be persistent. Colonoscopy revealed that it was a carcinoma. Another not so common cause of acute abdominal pain in colorectal cancer is acute appendicitis, and it results from obstruction of the appendix by a cecal cancer. It's seen especially in elderly patients, and it is the cause of an acute appendicitis in approximately 10 to 25% of elderly patients. Failure to identify cecal cancer may lead to incomplete treatment. And this is an example of same. Patient presents with a dilated, enlarged appendix adjacent to the appendix in the cecum. Once again, the suggestion of thickening of the walls of the cecum. This was initially thought, once again, to be due to collapse of the cecum, non-distension of the cecum. 6 months later, she has a florid mass, now in the right lower quadrant, cecal carcinoma. So in summary, the signs and symptoms of an acute abdomen are non-specific, even in cases of colorectal cancer. CT is the modality of choice for the investigation of acute abdominal pain in colorectal cancer and unsuspected colorectal cancer. Careful and diligent assessment of the non-prepared colon in all CT images of the abdomen and pelvis is important, as it ensures that incidental colorectal malignancy is not missed, especially in older patients. And clinicians should be aware of the limitations of the non-CT colonography abdominal CT. Thank you very much for your time and attention.
Wow, thank you very much for that, Dr. Grant. If you guys have any questions, I'd like you to post them for us, please, in the Q&A section, and I would put those forward to the presenters at the end of each segment, at the end of each presentation. That was very insightful for us, and a good reminder for us in terms of when to use CT and what to look for. I found it particularly interesting about that, the cecal thickening, and down the line it turned out to be malignancy. I would also like to remember, which I would try to be stressing multiple times throughout this symposium, that we should all remember to send our patients, whatever form it is, for colon cancer screening in order to prevent these cases where they would end up coming with an acute abdomen to Dr. Grant et al. for scanning. So we just all need to remember that. I've seen several patients, and a lot of them are saying that they were unaware of the need for screening. So I think there are almost 150 of us online here now, and so each of us can spread the word to the multiple patients that we have to try and reduce this preventable malignancy. Thank you very much, Dr. Grant. And as I'm seeing no questions here at the moment, I'm going to go ahead and introduce our next presenter, Dr. Dwight Lowe. Dr. Lowe is a well-known oncologist, hematologist, consultant at the University Hospital of the West Indies. He also did his MBBS and his DM at the University of the West Indies. And interestingly, I understand he's an art collector. I suspect the art behind him here in the image might be some of that collection. And I'd just like to welcome Dr. Lowe. Thank you very much for joining us here today. And we look forward to your presentation on molecular profiling in colorectal cancer and its impact on therapy and the challenges in our situation, which is this resource-limited environment. Please go ahead. Thank you very much for coming.
Hi, good morning. Confirming I'm being heard clearly?
Yes, I'm hearing you now.
All right. Okay, good morning, everyone. But first of all, let me start by thanking the organizers of the symposium for inviting me to speak. Colorectal cancer, as is being said or has been said before, is near and dear to many. And with it being the third most common cancer, is deserving of its own symposium and focus, which is why we're here this morning. So when I was asked to speak about colorectal cancer, I thought it would be appropriate to look at molecular profiling, since we're very much mature and steeped in the era of precision medicine, personalized or individualized care, which is really based on biomarkers and molecular targets. So I chose to look at where we are, how we've come to this crossroads in terms of our therapy, and where we hopefully would be going. I will have to apologize, but I have no control on my side, so I'll ask you to advance for me, please. Next slide. So the outline is really going to quickly go through the epidemiology with what most persons are familiar with in terms of our local setting. Look at the prognosis in metastatic colorectal cancer, because a lot of this information that we're going to discuss is appropriately geared towards metastatic disease. Although there are some settings where you're going to see as well that early stage disease may have some role to play in terms of tumor biology and discerning whether or not there's need for intervention. Tumor biology is absolutely important, and knowledge of that is important because this then leads to what you can do for therapeutic impact. What druggable targets can you recognize in your patients? And although we're moving ahead and science is leading ahead, we know we have challenges in our own settings in a resource-limited environment. How do we maneuver that? How do we get the best for our patients? And how do we work with the limitations that we have? And I'll try to apply some of that quickly into one or two clinical scenarios to sort of showcase what we're talking about and then just summarize. Next slide. So it's the third most common cancer, as we're familiar with in both sexes. Based on data from WIMJ 2010, the Jamaica Cancer Society has reported 17.2 per 100,000 for men and 12.8 per 100,000 for women, with a peak incidence at age 70 with an average range of 55 to 75 years. It accounts for significant mortality in terms of cancer-related mortality. It's the fourth leading cause of cancer-related mortality in men, and third in women. Next slide, please. So why the focus on metastatic disease? That's largely because a good percentage, up to 20% of patients will present with metastatic disease. So that's a significant crop of the population. And it's important to understand that metastatic disease has a poor prognosis. So you're looking at 10.3% 5-year survival rates without any intervention, with an average of 6 to 12 months. However, having said that, not everyone demonstrates the same sort of time period or progression-free survival. So heterogeneity is significant within this group. And you can see this because some patients with metastatic disease are still resectable. And if you successfully resect them, you can get 30 to 50% 5-year survival, which is significant. However, in the non-resectable case, you're seeing the difference there. Next slide. So what are the reasons for this heterogeneity? Well, the disease characteristics that we are all familiar with, tumor burden, whether you're able to do surgery or not, so the stage. But the site of metastasis is also important because not every site of metastasis has the same prognostic benefit or importance. So liver disease is well known to have perhaps the best prognosis, and this will be based on institutional practice and expertise, the number of lesions, how many lobes are involved, etc. But the site of metastasis is important because this differs from lungs and bone, so that would have a poor prognosis. But based on what we know now, molecules or biological molecules will have an important part to play. Of course, the performance of each patient will always have to be considered in terms of comorbidity. Next slide, please. So the biological hallmarks of colorectal cancer, we've all been familiar, or we're all familiar with the pathology lectures of, the adenocarcinoma sequence. And so this is sort of a revision. So in terms of the hallmarks, we're looking at defective mismatch repair. We're also looking at chromosomal instability, so the mutations that take place along the EGFR pathway, and also epithelial mesenchymal transition. Next slide. So when we look at the mismatch repair, we should remind ourselves what are we talking about here. So DNA, as you're familiar with, is comprised of proteins or base pairs along repeated sequences. So there are segments. And so each of these base pair and segments will constitute or comprise what is known as the microsatellite, or an arm of the DNA. And we have normal occurring genes, mismatch repair, genes that will prevent or repair. So as DNA, as time progresses, is prone to in accidents, damage, mismatch repair, mismatch damage, etc. So these proteins are able to go in and repair in an orderly manner. So the proficiency of these proteins based on normal genes, MMR genes, is going to be integral to maintenance of a normal system of proliferation and differentiation, and then proceeding to apoptosis. In cases where these genes are mutated, or if there's inactivation, then what happens is that this regulatory process of the mismatch repair sequence is not carried out, and therefore these microsatellites become unstable, or the term is called microsatellite instability. So we refer to them as microsatellite instability high tumors. And because of this MSI high feature, these cells no longer respond to the usual regulatory mechanisms. They become a bit autonomous. They proliferate and they differentiate at their own rates, and therefore gives rise to potentially sporadic colorectal cancer, or in germline mutations in hereditary colon cancer syndrome, such as Lynch syndrome or HNPCC. Next slide, please. So this is just a cartoon of what happens here, just to make it a little bit more relatable. So these MSI tumors, or microsatellite instability high tumors, will comprise cells which will then display what we call immunogenic neoantigens. So if you look at the figure there, you'll see those immunogenic neoantigens at the end. They are capable now of attracting and binding the normal circulatory cytotoxic T lymphocyte. And these are part of your usual sort of humoral mechanism in terms of mechanism in terms of keeping tumor cells in check. But these MSI cells have the distinct capacity to bind and lock the cytotoxic T cells by virtue of the PD-L1 receptors and PD-1 receptors, PD-L1 ligand and PD-1 receptors. When that happens, the T cell is no longer able to function with its cytotoxic function to kill and get rid of these tumor cells. And what happens is that tumor proliferates, infiltrates, and then it begins to migrate. Next slide. So with these MSI high colorectal cancers, we have some distinct features. So we see that this tends to happen in younger age patients, females slightly more predominant than males. We have a tendency for right-sidedness in terms of right-sided lesions, cecal lesions, etc. And the histology pathologist will tell you have particular features. They're poorly differentiated tumors, tend to be mucinous, and also they are also usually associated with more poor prognostic mutations like BRAF mutations. So this whole constellation of features then gives rise to disease that's more aggressive and tend to present with more advanced disease with nodal and peritoneal involvement. Next slide. So what is the impact? So there is a prognostic and a predictive impact. So for the prognostic impact, MSI-high tumors in stage 4 disease usually confers poorer prognosis or unfavorable prognosis. But in stage 2, we see a different scenario where in stage 2, MSI-high tumors and patients with MSI-high features and confirmed MSI-high status tend to have a more favorable outcome. But we're going to get a little bit into the meat of that, and we'll see in circumstances where despite that, there may be a different approach or may have to be a different approach. It is predictive because in the setting of metastatic or colorectal cancer, these patients with MSI-high tumors tend to be more responsive to immunotherapy for the exact reason we outlined in the diagram that we just looked at. Okay, so immunotherapy, we can begin to know what we can use now to target these patients. But it's also predictive for stage 2 patients who, in the setting of MSI-high features and characteristics, and it's proven to be MSI-high, may suffer more the deleterious effects of treatment. And therefore, one has to be cautious and one has to bear in all several other factors when determining if a patient with stage 2 should be treated. So it has prognostic and predictive value. So the recommendation really, as you can see, when it comes to MSI status and MMR testing, it should be done in all patients with colorectal cancer. Now, looking in at resource-limited environment, there is the FISH and PCR are not available locally, and that has to be done overseas at a significant cost. IHC, there is also the IHC version of this test because you're looking for you're detecting the proteins that these genes would secrete. Again, this is also has to be accessed overseas at a cost. But if, for example, we were able to do the IHC locally, then we could perhaps have more patients access MSI-high testing at a more affordable cost and more readily. Important to note that MSI-high tumors account for about 20% of the sporadic colorectal cancers. Thanks. Next slide, please. So we went over the immunotherapy. This is just a better or clearer diagram showing you where the immunotherapy works, or anti-PD-1 antibodies. So if you can see the tumor cell with the PD-L1 ligand, the PD-1 receptor of the T cell, if you can interfere or block that with an anti-PD-1 antibody, then you will then free the T cell to then become activated and carry out its cytotoxic function and therefore cause immune cell death of the tumor cell. Next slide. Right, so these findings, these features, and these studies gave rise to several trials, keynote trials with many different numbers, basically using the drug pembrolizumab in different solid tumors. You've heard about it perhaps in melanoma, you've heard about it in lung cancer, etc. And so as time has progressed, it has become more applicable in many of the solid tumors. So this graph here and the results of this trial, keynote trial, demonstrates the benefit of pembrolizumab over standard chemotherapy in terms of an increased progression-free survival for patients. So this demonstrates that pembrolizumab does outperform standard 5-fluorouracil-based chemotherapy with even additional agents like irinotecan and Avastin in terms of response to therapy and progression-free survival. Next slide. So the impact there, with that finding in 2017, the FDA approved the use of pembrolizumab. But when the first approval came out, it was in the third-line setting, and therefore patients would have had to have demonstrated failure to two previous lines of therapy. Pembrolizumab has now been brought forward, and therefore this can also be now used in the first-line setting. Next slide. So we move on to the chromosomal instabilities. So the EGFR pathway is a very important pathway, and epidemial growth factor receptor pathway. It utilizes and has several proteins which are going to be important for signal transduction and the whole control of proliferation and differentiation of cells. The next slide will show a cartoon, which will make it a little bit more applicable. Next slide. So here the EGFR receptor, the epidermal growth factor receptor, sits as a transmembrane receptor spanning both extracellular and intracellular compartment. And as you can see, it has a very intimate network of subsequent proteins down its signal transduction pathway. We can see RAS at top, followed by RAF, MK, and MAK. Now, these in their normal functioning states will have orderly cell growth. However, mutations can interfere with this proliferation. Next slide. So we start to look at RAS. We have RAS at the top. So there's KRAS and there's NRAS. What is KRAS? So this is a gene for the RAS protein in the epidermal growth factor receptor signaling pathway as shown there. Mutations, cancer, about 40% of cases. The type of mutation has its own prognostic importance. So we have what is called the wild type or unmutated KRAS, which is seen in about 60% of cases of colorectal cancer. And it's significant because it has a predictive response to a particular drug called cetuximab. So that's an anti-EGFR or EGFR receptor inhibitor agent. There is also the mutant version, so mutated KRAS. So the unmutated is called the wild type, which gives you information and can tell you that these patients will respond, and patients do respond well to cetuximab. But the mutants tend not to have the same benefit, and therefore knowing if patients are KRAS wild type or mutated will help to direct what therapy you give. Next slide. So I'm not sure how many of my colleagues are here, if any, but if we look back on these very old slides, or relatively old slides, so these are from 2004, we remember a time when there was actually a sort of a drug pharma competition going on between bevacizumab and cetuximab. Bevacizumab did come out as the anti-EGFR VEGF, sorry, not anti-EGFR, anti-VEGF therapy, vascular endothelial growth factor receptor therapy, which basically reduces or shuts down blood vessel supply, abnormal blood vessel supply to tumors. And that did come out as first line prior to cetuximab in combination with FOLFIRI and FOLFOX and had a distinct advantage. However, as time went by and trials matured, as you can move to the next slide, results started to become more skewed towards cetuximab. So on the right, you see the KRAS wild type with cetuximab and FOLFOX in orange, and the blue line represents FOLFOX, which is a sort of standard backbone first-line therapy, combination with 5-fluorouracil and oxaliplatin. And you can see in the right KRAS wild type setting, there's a definite benefit in terms of progression-free survival with the orange Kaplan curve above. In the mutant state, we not only realized that it did not have the same benefit, but we also realized it seemed to have had a deleterious effect. And so with cetuximab in the KRAS mutant setting, you see the orange line below the standard. So you can see there that in knowing the mutational status, we can better offer agents to these patients. Next slide. Okay, so what's the impact here? Based on these studies and the maturation of the data, we then had the FDA approval of FOLFIRI and cetuximab in the first line setting, surpassing FOLFIRI and bevacizumab. And this was in 2012. But since 2012, there have been other monoclonal antibodies, panitumumab, based on the PRIME and ASPECT trials, which have then since gotten similar first-line approval. So we now have other agents that we can use in the first-line setting in your KRAS wild type. However, is this going to be the same benefit in all KRAS wild type patients? The answer is no, because sidedness matters. So it does matter what side this tumor is on, whether it's a left-sided colonic or a right-sided colonic. And that's because right-sided tumors tend to harbor more of the poor prognostic features and more of the unfavorable molecular mutations, so the BRAF mutations or MSI high, NTRK mutations, etc. So this is specifically for left-sided KRAS wild-type tumors. Next slide. Okay, so what do we do with for patients with the mutations, for mutant KRAS? So bevacizumab still survives in this setting and can be offered in combination with FOLFOX and FOLFIRI. And it is still, having said that, bevacizumab is still effective in your KRAS wild-type patients, whether left side or right side. So there's still an advantage. However, in the left-sided KRAS wild-type patient, cetuximab has the definite benefit. There are other agents such as vemurafenib, because could we change to the next slide, please? Right, so this is just another cartoon showing how bevacizumab works, that sort of anti-VEGF vascular endothelial growth factor inhibitor. So basically causes regression of abnormal vasculature to tumor and more normal ordered blood vessel supply, which can then deliver chemotherapy much more effectively. Next slide, please. BRAF. Okay, so we've left the MSI high, we've spoken about KRAS, which also is applicable to NRAS. They share similar features. But BRAF, how is this any different? So we see that mutations in the BRAF are present in about 8 to 12% of patients with advanced colorectal cancer. And the V600B mutation tends to be the most common. And if there is a mutant BRAF, it is connotated BRAF M mutant. So MT, that's how it's written there. Because of this mutation, there's an aberrant activation of the subsequent transduction pathways below BRAF. And therefore, again, you get the disordered proliferation and differentiation and autonomy. Again, these tumors tend to be right-sided. And we spoke about the co-expression with MSI features. So MSI high feature, high tumors tend to also or may also express BRAF mutation. Patients who are BRAF mutants tend to be chemo resistant. So we know that there's going to be difficulty from day one with therapy. They are likely to progress. They may have short responses, but tend to progress over time. So this is a hallmark or biomarker of a poor prognosis. And for BRAF mutants, you tend to have to combine a full armamentarium of chemotherapy, your anti-VEGF like your bevacizumab, as well as your epithelial growth factor receptor inhibitors. Next slide. So how do we approach BRAF patients and what's the impact on therapy? So we want to know, are these patients MSI high? Are these tumors MSI high? Because that's a good algorithm start. If it is MSI high, then you know that immunotherapy can be offered. And you see here, it's brought up in the first line. However, if patients progress following immunotherapy, we can bring in other BRAF inhibitors like vemurafenib or eccorafenib. And there is a benefit in combining with cetuximab, which is used in the KRAS wild type. So we see a sort of synergistic benefit of the BRAF inhibitor plus cetuximab in the MSI high type disease. If this is MSI low, then your multi-agent chemotherapy triplet, FOLFOXIRI with irinotecan as well as oxaliplatin, as well as the addition of bevacizumab is going to be important. You see here, you're pretty much throwing as much agents at this disease as possible. And this is because of its primary chemo-resistant nature. Next slide. Looking at HER2, so we've heard about HER2 in breast scans, and you're probably wondering, why are we talking about HER2 in colorectal cancer? And that's because there is application and use of HER2 testing and looking for the gene amplification, because we see that in about 3 to 5% of metastatic colorectal cancer, the HER2 gene is over-amplified, causing EGFR overexpression. So the HER2 is basically a human epidermal growth factor receptor. It's a proto-oncogene encoding for the EGFR. and therefore it takes part in that whole regulatory mechanism. If the gene is over-amplified and the EGFR receptor is overexpressed, again, that signal transduction pathway is overstimulated and you get rise to tumorigenesis. Again, HER2 overexpression is a negative predictor or biomarker, as it tells you that these tumors are likely not to respond to anti-EGFR therapy and will need HER2 blockade. Next slide. So the impact here is that we have now moved away from the anti-EGFR therapy in this setting for HER2 positive patients. And based on the Mountaineer study, which recently concluded in January, leading to an FDA accelerated approval, we now have the benefit or the possible benefit of combining dual HER2 agents. So tucatinib and trastuzumab, you know trastuzumab, that's Herceptin, you hear about it in breast cancer. Tucatinib is also used in breast cancer. So it's the same molecules, but it's being applied in the colorectal cancer setting. And here is dual combination, and it is applicable in the third line. Next slide. Okay, so wrapping up, we can see that the guidelines, therapeutic guidelines in colorectal cancer have shifted, and the current NCCN guidelines are molecular-based guidelines. And you may be thinking to yourself, what are we to do? And we do these tests, we get these tests done for our patients, but there are limitations, because you can see with each step of it in terms of your newly diagnosed patient, you need to know the KRAS, the NRAS, the BRAF status, MSI, HER2, and there comes a challenge in cost and accessibility, and therefore not many patients or not all patients will benefit from this. But for those who are able to, and you try your best to get as many done as possible, you know that the wild-type, KRAS wild-type patients will benefit if left-sided tumors will benefit from cetuximab. If they are right-sided, however, cetuximab will not have any significant impact. Right-sided tumors tend to be more MSI high and BRAF, so immunotherapy there is going to be perhaps more applicable if you can get that as well. And of course, the HER2 status for your dual HER2 blockade. So I think I'm going to move to two examples, and then we'll finish with the presentation. Next slide. Okay, so the limitations in our setting, we've spoken about them. Cost, a big factor. So immunohistochemistry is the more affordable of the options when compared to FISH, PCR, or next generation sequencing. But not all of these molecular targets can be assessed with immunohistochemistry. So MSI is one of those. Since there is encoding of the gene encodes for the protein, you can test or use IHC to detect that protein. But for some of the other ones, for the KRAS, etc., it's usually more the molecular, the FISH and the next generation sequencing, which can cost sometimes upwards of $850 US in getting a panel done. Access, so yes, this has to be sent overseas. So we don't currently have in-house facilities to do that, and therefore it adds to time, determination of what's best, delays, etc. In our situation, we're all familiar with the impact of poor tissue preservation, and so samples get to the lab after an inordinate delay. Sometimes they're forgotten in theater, there's not enough formaldehyde, and therefore the tissue preservation is significantly impacted, and there's significant tissue necrosis. So you can't do these tests reliably on necrotic or poorly preserved tissue. And therefore, that is also a challenge in our setting. Drug cost, of course, we need not say that, but just to highlight that pembrolizumab is approximately 1.3 million every 3 weeks. And therefore, you can see that cost. Next slide. All right, so just going to wrap up with application to a case, to two cases. So the first case, we have a 53-year-old male who presented with a right-sided cecal colonic cancer. So he was diagnosed, had his surgery. He had adjuvant therapy. At the time, it was in 2014. So he had the standard backbone of modified FOLFOX6 for 6 courses. And this was in keeping with the standard therapy at the time. He did well, continued surveillance, but in 2017 was noted to have an elevated CEA, and his CT scans demonstrated peritoneal disease, so he had progressed. So we proceeded, and this was a patient who was able, to access and was of means with insurance, etc. And so we were able to get molecular testing done. But notice it was still not the full panel because of preservation issues. So KRAS, the tumor was found to be KRAS wild type, but as you can see, it's a right-sided tumor, and he's MSI high and he's BRAF mutated. So having seen KRAS wild type, you might think, okay, he could benefit from cetuximab, but no, it's a right-sided lesion. And remember, there's not much of a benefit there for right-sided because of the MSI high and BRAF associated mutations, which he also demonstrated. So he proceeded, and I gave him Zeliri and bevacizumab. So that is capecitabine plus irinotecan. And he did well on that, received 6 cycles. He wanted a break, start of chemotherapy. He wanted to just observe. So he observed for a while, but then he progressed again and he started back chemotherapy. Well, actually, he was maintained. So he got maintenance capecitabine and bevacizumab all the way up to January 2019. And then that's when he took a break. So this maintenance was an option. It's a recognized option to give patients somewhat of a bit of a break, but it still incorporates significant agents, the 5-fluorouracil and the anti-VEGF therapy. Now, immunotherapy was discussed at day 1 when we got MSI high features and BRAF mutation. However, the toxicity in terms of the side effects associated with it made him reluctant because pembrolizumab is associated, or immunotherapy is associated with increased risk of autoimmune complications, pleuritis, hepatitis, you name them. And so he was hesitant about it. So it wasn't an issue of cost, it was what he wanted to use in terms of quality of life. So we kept delaying. So after the maintenance and he was observed and did well, he progressed again. He mentioned, of course, avoiding pembrolizumab. And so we used trifluridine tiprosil, which is another 5-fluoropyrimidine with a slightly different mechanism of action. And that was able to bring about some quality of life and control. However, it progressed after that, and there was no avoiding it. We had to use pembrolizumab. But unfortunately, it came too late at times. So he only had 2 cycles. He had some benefit, had improvement in quality of life, but I believe if he had more of an upfront use, he would have had perhaps a better outcome. So he died subsequently. But nonetheless, he did very well up until 2020. So this is a patient who's metastatic with KRAS wild type, MSI, and BRAF mutated. So let's go to the second case, and then we wrap up with that. So the second case, this is a 45-year-old woman with mixed connective tissue disease. So she had her own issues coming into this period of her life on many agents, methotrexate, hydroxychloroquine. She had an interesting history with polyps in the family. She recognized that there was a cousin and her that there may have been an uncle. She had 2 aunts. One aunt definitely she knew about, and another aunt she suspected with breast cancer. So the history was a little bit concerning at the start. So she had a stage 2 left-sided sigmoid tumor diagnosed in March 2021. So we spoke about stage 2 disease and the benefit of knowing MSI status. So for her, this would have been the only profile that would be applicable in the stage 2 setting, because KRAS, BRAF, etc. are more applicable in the metastatic setting. However, she was seen to be high risk because at histology, she had lymphovascular invasion, and we saw that there was inadequate nodal dissection, so less than 12 nodes were removed. So she is automatically deemed a high-risk stage 2 patient. Therefore, you would have to now combine that with your MSI high features and try and decide for what is the best approach for this patient. We know typically MSI high features confer a better prognosis or more favorable prognosis in the stage 2 patient, but this is not the typical stage 2 patient, because we see here the IHC detected PMS2 deficiency, which of course raised the concern for Lynch syndrome. Marker didn't fit the full profile in terms of tumors. There was no history of ovarian or endometrial cancer, etc., but nonetheless a consideration. So germline testing was arranged for her, and this came back negative. So this didn't confirm the original thought in terms of the IHC here. The IHC is demonstrated PMS2 deficiency, but germline mutation was not detected. So this was a difficult discussion because we had to discuss risk versus benefit. Here is a patient that is recognized to be at high risk, but has significant comorbidities. 5-fluorouracil in the setting of MSI high features can be significantly toxic and deleterious, and she already has mixed connective tissue disease and other agents, methotrexate, hydroxychloroquine, which can interfere. So despite the leaning more towards therapy, she chose not to do therapy and just did surveillance. However, her disease and her biology played an important part, and soon after that, within January 2022, she recurred. This was an anastomotic site lesion. So I think she was convinced, and we were able to get her on combination therapy. It hasn't been easy. It has been a difficult journey. We have had to adjust doses, and I can definitely see where 5-fluorouracil in the setting of MSI high is much more of a challenge. But then I don't know if I can be fair to say it's all 5-FU based, given her comorbidities and her other drugs. Nonetheless, she has completed successfully and is currently so next slide. So just to show what the toxicity can be in the limited resource setting, and just to let you know that these were figures generated in 2017. So add inflation, add the European war, add supply issues. Bevacizumab is currently at 346,000 plus per vial. Cetuximab has gone further to about 7,200, and pembrolizumab is closer to 1.5. So you can see that it's not just access and preservation cost. All right. So let's get my summary slide. Next slide. So just in closing, we recognize that it's a heterogeneous disease that we're dealing with here with colorectal cancer. The tumor biology is of significant importance. It's the driver of the disease. And if we can identify what molecules are involved, we can identify potential targets. So molecular profiling is absolutely integral to treatment. Yes, we do have challenges in our resource limited environment, but I know we have other players from the policy arm of the healthcare sector. So we could probably look at public-private partnerships, because drug pharma is usually willing to upfront or facilitate testing. But of course, this is at the distinct benefit of perhaps getting patients to afford their drugs. So if you can have public-private partnerships where we have the standard molecular testing done, and then drugs subsidized, then it would be a win-win situation. There is foundation medicine, and these next generation sequencing is at about $4,000 US. So you can see where the cost is. So this is where I'll close. And I think questions will perhaps be at the end. Thank you.
Wow, thank you, Dr. Lowe. That was a lot. Thank you for that excellent presentation. You really put forth a lot of important points. And there was a question, but I believe it was answered by an anonymous attendee. Please indicate the cost and availability in Jamaica of these targeted therapies. So I believe that was answered with one of your latter slides. Thank you very much. I wanted to highlight certain things that you had mentioned. You did say to send all the patients for IHC, because that was one of the things that I was going to discuss with you. And my question is, in the public setting, are those drugs that you mentioned available? Because I have had patients that have been in the UE system, and then they say that they have been told or transferred essentially to KPH. My question is, or whichever other public hospital, the question is it the same drugs that you're mentioning here that they're able to get in the public setting, or they're getting something, general, more cost effective?
Okay, so they will access the standard therapies, the 5-fluorouracil based therapies. So 5-fluorouracil, oxaliplatin, leucovorin, the Folfox regime, the standard backbone, is available in the public health system. However, the molecular agents, the targets, the druggable targets in terms of pembrolizumab, EGFR inhibitors, all of those things, those are not available. And patients would have to buy. But I'd hasten to mention that there is the compassionate fund from the Ministry of Health. They do their best, but the cap per patient is about 800,000 Jamaican dollars. So you can begin to see that it would be somewhat of a challenge because it wouldn't start for some in pembrolizumab for 1.3 million.
And that's what
yeah, but yes, they can access. So for example, they do get assistance for if they're trying to get bevacizumab, etc. But it's not a standard drug provided in the public health system. They'll get the Folfox, they'll get Xelox, they'll get irinotecan-based therapy. So they'll get the chemotherapy backbone, but the drug, the special targets.
Directed ones.
Yeah.
Okay. Okay. And just another important point to highlight from what you said is even though some of the patients have metastatic disease, all is not lost. They can still be resected, which is essentially bringing us up towards the surgical point that's coming up next. Thank you very much, Dr. Lowe. Very insightful talk. Hold on one second. Any NHF subsidy on treatments? Another question there.
Okay, NHF subsidy. Okay,
NHF.
so National Health Fund covers two cancers predominantly, breast and prostate. There is work ongoing to include others, but officially those are the two cancers. So no, it doesn't necessarily cover colorectal cancer drugs, but as I said, patients can access these therapies within the government system for free, providing the drugs are available. Yeah, so once they have them, they will get them.
Okay, okay. Thank you, Dr. Lowe. And then just to backtrack a bit, in case anybody hasn't gotten a chance to read it, there was a question there earlier for Dr. Grant, whether single IV contrast, I believe, CT is just as efficacious with detecting cancer versus double or triple contrast. And so Dr. Grant has answered that here in the chat. Single phase post-IV contrast can demonstrate colonic lesions, but dual phase imaging is best when evaluating both the colon as well as the liver. And as Dr. Lowe just demonstrated, important to know whether there is metastasis to the liver. So ideally, the contrast CT, double contrast, triple contrast CT would be ideal. Thank you guys very much. I think we're doing very well regarding time. One other question here, which I think is for Dr. Lowe. Doesn't the high cost of targeted therapies decrease access to healthcare for the low-income population? Well, you're muted.
Okay.
Oh.
Yeah. Right. Go again. Does the high cost?
The high cost of targeted therapies decrease access to healthcare for the low-income population, which I think is
so it shouldn't decrease access to healthcare because patients should still be diagnosed, they should still be worked up. What it will limit is your offering, how patients can access these agents. So we do discuss with all patients, the benefit of these special tests, but it will become, the challenge is getting them to be able to, or them being able to afford it. So it's really down to cost. So it's not that they should access healthcare services less, they should still be diagnosed and you can stage them appropriately, etc. But it's going the extra mile to see what molecular profiles they demonstrate.
Okay, thank you very much. All right, so this brings us to the surgical aspect of it, and it's with great pleasure that I introduce Dr. Kemba Peters. Dr. Peters is now at Cornwall Regional Hospital, a product of the University of the West Indies, recent graduate, and now post DM2 consultant consultant level at Cornwall Regional. She I've recently learned is from a family of 7, a middle child of 5. So Dr. Peters is going to be talking to us today on the surgeon and stage 4 colorectal cancer. Please go ahead, Dr. Peters.
Okay, good morning. So I am Kemba Peters. I first want to thank the Jamaica Cancer Society for the opportunity to present at this their annual colon cancer symposium. Colon cancer continues to be topical in the field of oncology. The topic that I will be presenting today is entitled The Surgeon and Stage 4 Colorectal Cancer. And stage 4 colorectal cancer suggests that there has been spread of cancer beyond the colon and the surrounding lymph nodes. I hope through this presentation to raise awareness to our audience, physicians, patients, caregivers, and allied medical colleagues that the treatment of stage 4 colon cancer has evolved, and we have moved away from the traditional thinking of palliative care to continued explorations for opportunities for treatment with curative intent. And surgery is an important modality that we now utilize to assist in getting improved overall outcomes for these patients. Colon cancer is the 3rd most common cancer locally. One study done by Plummer et al., a retrospective review, determined that 27% of patients in that cohort had stage 4 disease. This is similar to what we see in international literature, where 20 to 30% of patients already have stage 4 disease at presentation. The initial 5-year overall survival quoted for stage 4 colon cancer has been as low as 10%. That means 90% of patients will die at 5 years once diagnosed with stage 4 colon cancer. What we have seen over the last few years is significant improvement in the overall survival. One, because of improvements in chemotherapy, and finally, with improvements in modality, in other modalities such as surgery and systemic therapy, some databases actually record overall survival rates as high as 60%. So what is clear, and what most of our literature suggests, is that surgery provides the greatest chance for cure and long-term survival. 20 to 30% of patients can remain free of recurrence long-term and achieve cure. I highlighted this study by Sudo et al., which was published in the World Journal of Surgical Oncology, and he highlighted favorable independent prognostic factors seen in stage 4 colorectal cancer. That included CEA negativity, a differentiated histology, as well as left-sided tumor. What I've highlighted again is R0 resection, again emphasizing the importance of surgical resection, surgical removal of both the primary as well as the metastatic site. So essentially, we're seeing that surgery is significant in improving the outcome of these patients. The initial management, of course, for patients who present with stage 4 cancer should be individualized. And again, we are utilizing surgery with a combination of agents. So surgery, chemotherapy, immunotherapy, and how we approach these patients may differ depending on the patient's presentation, as well as depending on specific factors related to the cancer. I'd like to highlight a case. So this is the case of a 41-year-old man with no prior medical illnesses who presented to his GP with a history of bleed per rectum. His abdominal and rectal examinations were unremarkable. Colonoscopy and biopsy revealed an adenocarcinoma 23 centimeters proximal to the anal verge, and staging CT chest, abdomen, and pelvis revealed a lesion to the segment 5 of the liver. The CA was noted to be 6. An MRI abdomen was done, and this is usually recommended in the setting of metastatic liver disease because it assists in identifying sub-centimeter nodules that's not always picked up on CT. His MRI abdomen identified no sub-centimeter deposits. His case was discussed at a multidisciplinary tumor board meeting. And again, I've highlighted this particular aspect of his management because I must emphasize the importance of the multidisciplinary team in the management of these patients. And there is data suggesting that patients whose case are discussed in this forum do have better survival outcomes. The plan arising from this meeting was to proceed with a simultaneous right hepatectomy and sigmoidectomy, followed by adjuvant chemotherapy. So the standard surgical resections that we have for patients who present with liver metastases often depends on the location of the metastatic deposit. So in our case, or the case I just highlighted, where our patient presented with a segment 5 lesion, he was offered a right hepatectomy. Similarly, if you just look at this graph, you'll see that we have other standard resections, such as the left hepatectomy for patients who present with lesions in 4A or 4B. We have a segmentectomy for patients who present with an isolated lesion, for example, just in segment 3. We do have non-anatomic resections that can be performed as well. For example, the wedge resection, which has been shown to give just as good outcomes as the segmentectomy. Other resections or standard resections that we have include the left extended hepatectomy, usually in the setting where the patient has multiple nodules that affects the left lobe, as well as perhaps at segment 8 or 5 on the right lobe. And the converse is true for the right extended hepatectomy. When we make a decision to proceed with hepatectomy for a patient, 3 main factors must be considered. One are patient factors. So the liver resection subject patients to significant physiologic stress, and patients with significant medical comorbidities, such as underlying liver disease or even cardiopulmonary disease, even in the setting of having an anatomically resectable disease, the perioperative risks sometimes are prohibitive to proceed with surgery. Tumor factors tend to be a very important aspect as well. And the tumor biology is an important factor, really, because it helps to predict the recurrence as well as the survival of these patients. There are numerous clinical prognostic tools that have been developed that help to determine the risk of recurrence after resection. And it helps to guide us as to which patients will benefit from upfront surgery versus a trial of initial upfront neoadjuvant chemotherapy. So what these clinical risk scores tell us is that a patient who, based on clinical pathological factors, a patient who has low risk, that is low risk of recurrence, low risk or better risk of, low risk of recurrence, is a patient who can proceed directly to surgery. Our patient, for example, and I'll use the FOUND criteria, which is most often used, but there are many. Our patient would have attained 1 point for the disease-free interval of less than 12 months since he presented with a synchronous lesion. So at the time of his presentation, he already had a metastatic deposit to the liver. He had 1 metastasis, so he was not assigned a point here, and his preoperative CEA level was 6. The metastatic deposit was known to be 3 centimeters, and he did have lymph node positive disease. So he would have obtained 2 points. But if we look at this criteria, which guides us as to which patients can have upfront surgery, based on this, he was still a candidate for upfront surgery. Patients who who has a high risk of recurrence, they usually should proceed with initial upfront chemotherapy. This will be followed by reassessment. And the benefit of that is to allow for assessment of the tumor biology or the aggressiveness of the tumor. A patient who progresses while having chemotherapy likely will not have benefited from a morbid procedure or procedure that entails significant physiological stress. The next factor that has to be considered is anatomic factors. And I highlight this one because traditionally, previous guidelines for resection for colorectal metastases actually place limits on the definition of resectability. So modern multidisciplinary consensus actually defines resectable mets as tumors that can be resected completely while leaving adequate liver remnants. So once we can obtain an R0 resection and have an adequate liver remnant or functional residual liver volume, then this patient is considered to be a candidate for surgery. So we have gone from the conventional indications, which initially placed a limit on the number of metastases, the size of the metastases, the presence of extrahepatic mets, as well as the ability to obtain a resection margin more than 1 centimeter, to now the modern aggressive approach, which says there's no limit on the number of metastases. If the patient has multiple bilobal metastases, we can use neoadjuvant chemotherapy, more complex staging procedures, or even combine resection with ablative therapy. There's no limit on the size. Pulmonary mets, if present, can be resected. We do accept a resection margin less than 1 centimeter, and we can combine this with ablative therapy or ablative treatment for that narrow margin. We now accept both, or we now include both synchronous and metachronous metastases. if there is involvement of the IVC, the inferior vena cava or hepatic vein, that can be resected with construction being performed. And even if there is involvement of the hepatic pedicle lymph nodes, that can also be resected. I will go a little bit into this a little later in the talk. So one of the most important things that the American Hepato-Pancreatic Biliary Association and the Society of Surgical Oncologists state is that the feasibility of hepatic resection should be based on 3 main criteria. 1, the ability to preserve 2 contiguous segments, the preservation of adequate vascular inflow and outflow, as well as biliary drainage, and the ability to preserve an adequate functional liver remnant, which is often more than 20% in the healthy liver. So when we discuss, or when we have a patient present with liver metastases, we still want to determine if they are initially resectable or initially unresectable. And based on what I've described to you in the earlier slides, we see that the definition of unresectable and resectability has changed significantly. So a patient who is considered to be unresectable at presentation, whether it's with synchronous mets or metochronous mets, is a patient who cannot be resected with curative intent by standard or complex or combined interventions. And the complex interventions include the stage hepatectomy, the portal vein, which includes portal vein embolization, or the ALPS procedure, which I will discuss now, or combined, that is combining both surgery as well as ablative strategies. So this, what I've added to my slides here, actually represents one of the complex or 2-stage hepatectomy procedures that we utilize for patients who have bilobal disease. So again, in the past, bilobal disease would have been a contraindication to proceed with surgery. Now we have 2 options. 1, the portal vein embolization, where the right portal vein is embolized, and this allows for slow hypertrophy of the left lobe of the liver. With that hypertrophy, it helps the patient to achieve greater liver volume so that they can achieve that more than 20% liver volume or functional liver remnant liver volume. Once the patient has had hypertrophy of the left lobe of the liver, and then a non-anatomic procedure can be done to remove the lesion within the left lobe of the liver. And that can be, again, a wedge resection or ablative procedures, which are now recognized as reasonable oncologic procedures in the setting of liver surgery. The ALPS procedure is the associating liver partition and portal vein ligation procedure. So this combines both portal vein embolization as well as partition of the right lobe and left lobe. And this procedure has come about because it allows faster or more rapid hypertrophy of the left lobe of the liver, the segment that we intend to leave in situ. And then there are a group of patients who will still be unresectable. While the majority of patients would have an initial trial of chemotherapy with an aim for conversion, the conversion rates that we actually see taking patients from unresectable liver disease to resectable is 5 to 7%, so it's low. So there are a group of patients who will remain unresectable, and so because of the successes that have been seen with liver transplant as it relates to hepatocellular carcinoma, there's been more work done looking at liver transplantation in the setting of colorectal liver metastases. There are 2 main prospective trials that look specifically at liver transplant and colorectal liver mets. That's the SECA trial and the SECA-2 trial. And they have quoted 5-year survival rates as high as 60% with liver transplantation and 83% respectively. The SECA-2 trial used a more stringent criteria and were able to obtain better overall survival rates. And the prerequisites for liver transplantation in patients with colorectal metastases include 1, completion of fluorouracil, oxaliplatin, or irinotecan-based chemotherapy. Upon completion of chemotherapy, they should then have an observation period of 6 months. During this observation period, the patient remains a reasonable candidate for liver transplant if there's no progression of the disease. And again, this is to allow for assessment of tumor biology. We're trying to assess how aggressive the tumor is and avoid a major surgical intervention that will be of no benefit to the patient. There are exclusions to patients or contraindications to patients who are considered to be candidates for liver transplant, and this is based on the poor prognostic factors. So patients with a V600 BRAF mutations are not candidates because this is a poor prognosis, and as Dr. Lowe highlighted in his previous talk, they tend to do poorly generally. Even with an initial response, they most times progress. If there's progression during bridging therapy or within 6 months of completion, so during the initial chemotherapy, if the patient progress, or during that observation period of 6 months. Patients who require immunotherapy are not considered to be candidates for liver transplant, and that's related to the immunosuppression required having gotten a liver transplant. And if there's an elevated CA, usually more than 80 with an increasing trend, that's also a contraindication. The trend tends to be more important, but even in the setting of a CA more than 80 with a decreasing trend, those patients are also considered to be a relative contraindication to liver transplant. And this is just a algorithm. I'm showing the approach to selecting patients for transplant in the setting of colorectal metastases. So again, a patient with metastatic colorectal cancer, if there's no evidence of extrahepatic metastatic disease, and the patient has non-resectable colorectal metastases, as well as fulfills the molecular criteria, that is no V600 BRAF mutation, what they should get in the setting, I'll start with metachronous disease, they should have bridging therapy to transplantation, an observation period of 6 months, followed by transplantable colorectal metastases. If they do not respond to transplant therapy or progress, then they will have palliative therapy subsequent to that. In the patients with synchronous disease, if they're asymptomatic, they should get initial chemotherapy. If there's no response to the chemotherapy, then they will move on to have palliative therapy. And if there is response to chemotherapy, then they can move on to have resection of the primary tumor, bridging therapy to transplantation, followed by an observation of 6 months before confirming that they are indeed a candidate for transplantation. So in the setting now of isolated lung metastases, so this is the most common site of extra-abdominal metastases, and 10% of patients will have isolated pulmonary metastases. 10 to 30% already known to have advanced disease will have pulmonary metastases. And again, the most important aspect of the management of these patients is that multidisciplinary tumor board meeting. Again, this has been shown to improve the survival as well as the outcomes to patients with stage 4 colorectal cancer. The 5-year and 10-year overall survival seen with patients undergoing surgical resection for lung metastases has been quoted as high as 35 to 70% in one article and 20 to 30% respectively. There's not a lot of robust data supporting resection. However, based on retrospective data and uncontrolled trials, it generally suggests that we tend to get better outcomes with resection compared to the other options for management of lung metastases, which can include active monitoring or even stereotactic radiation. The gold standard based on this evidence is resection. And the criteria for resection in patients with lung metastases include metastases that are completely resectable based on preoperative imaging. The patient has adequate cardiopulmonary reserve to tolerate this resection. The resection is technically feasible and the primary tumor is controlled or can be controlled. And if there is any extrapulmonary metastatic disease, then it can also be controlled with surgery or any other treatment modality. For patients, they also know that resection of one or more lung lesions may be indicated in other patients where there's a suspicion of a new primary lung cancer, there's symptomatic metastases, or tissue needs to be obtained for a novel therapeutic strategy. And the contraindications to lung metastases include brain mets, the presence of N2 nodal involvement, the inability to resect all areas of pulmonary involvement, and if the patient has a prior pneumonectomy. And this last point about a prior pneumonectomy is a relative contraindication. And the surgical options to patients who has lung metastases can be non-anatomical, so including a wedge resection. It can also be a segmentectomy, removing a segment of the lobe, or it can be a lobectomy or pneumonectomy. The majority of patients will undergo, especially in the setting of an oligometastatic site, a wedge resection or segmentectomy. And there's been no difference seen in the overall survival between the wedge resections and the segmentectomies, except that the segmentectomies tend to be associated with a lower relapse rate. So the recurrence rate was noted to be a little higher in the wedge resection group. But they are both reasonable options, and again, the decision to proceed should be determined in the multidisciplinary meeting. And the approaches, there's no difference between the approaches as it affects overall survival, and it can be via video-assisted thoracoscopy, or even a thoracotomy or sternotomy. So this is the case now. I will present a third case. A 66-year-old woman presented to A&E with obstipation and abdominal distension, as well as one episode of fecal appearing vomitus. Examination revealed a distended, soft, non-tender tympanic abdomen, and rectal exam was unremarkable. CT abdomen and pelvis confirmed large bowel obstruction secondary to a constricting lesion at the descending colon, and the right ovary was identified and thought to be enlarged and suspicious in appearance. An expiratory laparotomy was performed, a left hemicolectomy and bilateral oophorectomy was performed. So ovarian metastases is fairly common. 3 to 8% of women with colon cancer will present with ovarian metastases, and this can be synchronous or metachronous. So I refer to both groups. It generally represents a poor prognostic factor, especially if synchronous and bilateral. However, the approach, in keeping with surgery being the best chance, or one of offering the best chance of cure, the approach for these patients should be a bilateral oophorectomy. And this should be performed even in the setting where there's one abnormal ovary, because of the potential for microscopic disease in the contralateral ovary, as well as the development of metachronous metastases. So a 26-year-old presented with right-sided abdominal pain over 13 months. Her examination was unremarkable. CT abdomen, pelvis showed multiple discrete nodules and peritoneal thickening in the right paracardic gutter, concerning for peritoneal carcinomatosis. Colonoscopy and biopsy confirmed an adenocarcinoma of the cecum. Staging CT chest confirmed no evidence of pulmonary disease. Again, she was discussed at a multidisciplinary tumor board meeting, and the outcome was that she likely had stage 4 colon cancer with isolated peritoneal carcinomatosis. She went on to have a staging laparoscopy, and that was to determine her peritoneal carcinomatosis index, as this has implications in the final approach to the patient. Generally, based on newer trials, specifically coming from PUDI 7 trial, PCI less than 25 can be considered for definitive management of the peritoneal carcinomatosis. So she had a staging laparoscopy followed by induction chemotherapy, and this was to follow with a right hemicolectomy plus cytoreductive surgery and HIPEC. So just to note, peritoneal metastases is the second most common site of colon cancer intra-abdominal metastases, and that is second to, of course, liver metastases. Approximately 8 to 15% of patients will have peritoneal metastasis. And while systemic chemotherapy does show some improvement, it's marginal and not significant. So the median overall survival with systemic chemotherapy is thought to be 16.3 months, and surgery is expected to have a significant impact. So there are randomized controlled trials as well as meta-analyses that suggest cytoreductive chemotherapy and HIPEC, which is heated intraperitoneal chemotherapy, could significantly improve overall survival compared with systemic chemotherapy in selected patients. And one study quoted a survival rate of 22.3 months versus 12.5 months with just systemic chemotherapy. And the prognosis of colorectal cancer with peritoneal metastases was related to the completeness of the surgical resection. So the initial approach to these patients in determining if they are candidates for cytoreductive surgery is determining the peritoneal cancer index. And this was introduced by Sugar Baker initially in his approach to management of appendiceal tumors that had spread to the peritoneum. So the abdomen or the abdominal cavity is divided into 13 regions, And these 13 regions are examined and based to determine if there's any tumor present, for which a score of 0 will be given for that particular area in the abdomen, versus if there is tumor up to 0.5 centimeters or up to 5 centimeters or even more than 5 centimeters, for which a score of 3 will be given. The total score is calculated and a max score of 39 can be given based on the 13 regions that are going to be assessed. Again, traditionally, the thinking was a PCI 14 and less was eligible for surgery, but there is new data coming from the Prodigy trial, which utilized a score of less than 25. And the aim of cytoreductive surgery, once a patient is considered to be a candidate, is to obtain a completeness of cytoreduction score of 0 or 1. So 0 being absolutely no disease left back, and a CC1 being disease being present, but less than 0.25 centimeters. The decision for HIPEC, in addition to cytoreductive surgery, remains controversial, and there's no strong evidence supporting the use of HIPEC. In fact, the latest trial that came out, the same Prodigy 7 trial, suggests that there's no significant benefit in overall survival with the utility of HIPEC or adding HIPEC to cytoreductive surgery. With that information, currently, most of the major guidelines still continue to advocate for cytoreductive surgery as an important aspect of the management of patients with peritoneal carcinomatosis, again in well-selected patients, and they have suggested the use of intraperitoneal chemotherapy at this time in select patients. So in summary, all stage 4 colorectal cancer cases should be discussed in a multidisciplinary tumor board meeting. There are ongoing innovations to improve overall outcomes and survival among patients with metastatic colorectal cancer. The body of current literature suggests that surgery provides the greatest chance of cure and long-term survival in the appropriately selected candidates, of course, integrated with chemotherapy, immunotherapy, and other systemic therapies. I thank you for your attention.
Thank you very much, Dr. Kemba Peters. That was a very clear presentation. And I think the take home, in addition to the well-drilled point of multidisciplinary meeting, is that all is not lost in the patients that even have stage 4. It was, and correct me if I'm wrong, you said the patients with peritoneal carcinomatosis, they have it's 1 to 2 year survival. I think I got on that study. It's 1 to 2 year survival. That's with treatment, with the treatment that you had just discussed. Sorry, you're muted. You're muted, Dr. Peters.
Right. So I didn't give a median survival. I didn't give a median survival outcome, but I did say that, well, one study, specifically the study that was done by Verwal et al., he suggested that with cytoreductive surgery and HIPEC, he was able to obtain 22.3 months survival rate in his cohorts. And that was compared to a cohort that had just chemotherapy, and they had a survival rate of 12.5 months.
Okay.
So they have shown reasonable outcomes in selected studies.
Okay. And I don't see any questions for you in the chat. So I would just, well, you mentioned the case of the 26-year-old female with stage 4 cancer. And I mean, it's quite unfortunate that this stage of cancer is coming up more and more in the younger population. Did that patient have a family history of colon cancer?
No family history.
No family history. And then my last question was genetic testing done for her?
It was requested, not done. Okay. But she definitely would have been a person who requires genetic testing given her age and of diagnosis. Yes.
Right. Okay, thank you very much. If there are no other questions,
thank you.
I will proceed to our next presentation, which is going to be by Dr. Kern Pemberton. Dr. Pemberton is a clinical radiation oncologist, and acting head of Department of Radiation Oncology at the Kingston Public Hospital. So he is more than qualified to talk to us today on radiation in rectal cancer. Dr. Pemberton also works at St. Joseph's Hospital and Radiation Oncology Center of Jamaica and specializes in breast pelvic malignancies and has a special interest in stereotactic radiotherapy. He is a graduate of our beloved University of the West Indies and a fellow College of Radiation Oncologists from South Africa. And he also did his Part 1 certificate with the Royal College of Radiologists in the UK. So thank you very much, Dr. Pemberton, for taking time out of your Sunday morning to talk to us. Without further ado, go ahead.
Good morning, everyone. I feel so humbled and honored to present after such good presentations. So I'm Dr. King Pemberton. Today I'll be presenting on radiotherapy in rectal cancers. Can you confirm that you can hear me?
Yes, we can.
Awesome. Okay, let's get into it. Let's just move this up. Awesome. Okay, so I just need to move this to another area and actually fine. Okay. So we're going to talk about radiotherapy in rectal cancer. It's going to be a little bit simple in the beginning. So the approach to radiotherapy in rectal cancers, I use the PR approach, and I don't mean it in its clinical sense, nor in its public relations sense. It's the performance status versus the risk stratification. So when we talk about the performance status, we're talking about the age of the patient, symptoms. Are they bleeding? Are they having any obstructive symptoms? Leakage tends to be quite debilitating for some patients, and pain as well. All these things cumulatively determine the trajectory of the disease treatment. So in terms of the risk stratification, however, we look at the T stage, and we'll get into that in a bit, the nodal stage, the metastatic status. But more intricately speaking, we look at the location of both the tumor and the nodes, the extramural invasion, and that's just the ability of the tumor to grow into a vein, the circumferential resection margin, which we'll get into later, and the levator or sphincter involvement. Now, to the T stage, I want you to picture the rectum as a tube, and a number of organs in our body, they do have fat covering or fat padding. So that fat padding for the rectum is called the mesorectum, and then you have fascia around it. So back to the T stage, just think of the rectum of that as that tube, and in the middle, you can see that you have different T stages depending on its growth outward. So for T3, you can see here that they have different measurements in terms of distance growing outward. And for T4 and T4A and T4B, sorry, you can see that one is actually breaching the fascia and the other is actually touching an organ. So in terms of the location, we can use the ESMO guidelines in terms of the distance from the anal verge, quite simply put. And in terms of the EMVI, which we call the extramural venous invasion, simply put, just the tumor going into the vein. I'm not a radiologist, but you can see here you have varying degrees of extramural invasion, extramural venous invasion. And it's quite a good prognostic factor once seen on an MRI. Now, the circumferential resection margin, now going back to this fat padding, I want you to imagine that you have a garbage bin with garbage in it and a garbage bag, and you'd like to take out that garbage bag. When you take out that garbage bag, you'd want to make sure that it's not torn or the integrity of the bag hasn't been breached. When you actually do a total mesorectal excision, not a surgeon, but essentially what you're doing is taking out the rectum, the mesorectum, and all the nodes that could be in there. So it's quite important for the surgeons before an operation to understand or conceptualize that the circumferential resection margin is free. In this picture here, that circumferential resection margin, or let's just call it the garbage bag, is outlined in red. And as you can see here, the distance from the tumor to the red is measured in yellow. In this one, it looks quite close, but this other slide is quite obvious. The peculiarity of this slide shows that there's a lymph node in the mesorectum that has gone beyond the red line. The thing about it is all these factors cumulatively can help you sort of dictate the risk stratification. This is a nice table to use proposed by the ESMO guidelines, but just to make it simple for our viewers, you can talk about what's going on inside and what's going on outside. So for the inside, you're talking about if it's located high, middle, or low, how far grown it is in terms of from the inner epithelium of the rectum. Extramural venous invasion is important as well on the inside, as in terms of the inside of the mesorectum. On the outside, however, that's when things start to get tricky and dangerous. So if your circumferential resection margin is involved, if you have any breach of that sort of margin and it's growing outward into an organ, if you have sphincter involvement, and if you have a lymph node on the outside. And what I mean by a lymph node on the outside is if you look at this slice, the CT scan slice here, the white things on the side of the bones, and that red line represents the circumferential resection margin. A lymph node will be to the right or lateral to that. So I'm going to go into some cases now. We have a 45-year-old male with a good performance status. I'm so sorry, the thumbnail here is blocking part of my screen, but I'll just improvise. He complained of severe constipation, intermittent bloating, and low abdominal pain. He has one mesorectal lymph node, no EMVI, and a clear circumferential resection margin. Fortunately for him, there are no metastases in terms of the liver and the lungs on the CT scan. How would you treat him? So you have different options here. Long course chemoradiotherapy, we'll get into that later. Short course radiotherapy, sorry. Discussing this patient in the multidisciplinary team meeting, or total mesorectal excision. Okay, you can silently choose your answers. Discuss in the MDT, and I'm so glad that Dr. Peters brought it up earlier. The multidisciplinary team approach is prudent in the management of rectal cancer patients. What had happened in this case, because it's a similar case that we had seen in our setting, was the patient had an acute bowel obstruction secondary to his tumor. The worst scenario is to have a patient who has bowel obstruction whilst getting RT, especially if RT causes tumoral edema and swelling and can worsen bowel obstruction symptoms. So this patient luckily went on to have a diverting colostomy. The surgeons believe that it may be resectable, but what is the next step in management? Are you going to give neoadjuvant chemoradiotherapy? Are you going to just let him do the operation and then give him the chemoradiotherapy afterwards? Are you going to do an upfront operation? Or are you going to do neoadjuvant chemotherapy? Now, rectal cancer is one of those tricky things whereby varying jurisdictions do varying practices. But let's say the best option for this patient is neoadjuvant chemoradiotherapy. So we're consulting the patient.
So doctor, how does radiation work?
So radiation is an X-ray treatment that's used to treat rectal cancers. And this patient here, it just goes around the patient. It's specific to the site. So it's not going to go all over the body. You're not radioactive when you leave the center. And essentially what it does is it causes DNA damage. So it causes the DNA to break. What happens in that regard is that the cell becomes brain dead. So you still have the mitochondria and all these other lovely things that we learned about in med school that work, but the cell's brain is damaged. What happens is most living things procreate and go through a process called mitosis to make more cancer cells. And in doing so, you must have intact DNA. So when it's time for the cancer cell to do mitosis now with this brain dead or damaged DNA, they can't, and therefore the cancer cells dissipate or die. This is important for patients to understand because they'll come to you getting 25 treatments, and after 5 treatments, they're like, why isn't the cancer gone? Why aren't my symptoms gone? You have to be cognizant of the fact that you have to give the cell some time to go through the cell cycle and die and can't make any more, and that's how the cancer disappears. Now, we are pilots in our own right. We do something called simulations. This is a CT scan. This is how far we've come. We are now able to actually do slice by slice tumoral definition of the rectum and tell the machine to give the radiation to that area and that area only. So it's a very site-specific treatment, reducing side effects as the technology becomes more advanced.
Why do I need radiation, doctor?
And that's a good question, sir. So I use evidence-based medicine. So the history is there. In the 1970s, they actually started giving radiation right after the operation. And then the TME, the actual total mesorectal excision, came in the 1980s. The Dutch and the Swedish, they started giving it preoperatively, and then the British jumped on. And the main consensus is that there was a reduction in local recurrences for these patients. You have other studies coming along, but we're going to get into it as we go along.
Why is my treatment for 25 days?
Right, so your treatment is quite long, 5 weeks. We break up the treatment into days to allow recovery. So therefore, when we give a little bit every day, what you're doing is slowly beating down the tumor, and we're also allowing the normal cells to recover. Some of the changes that you can see during the treatment, which we term early side effects, are things like skin changes, urinary symptoms, burning, even sometimes some abdominal pain. Diarrhea is quite common because it's potentiated by the effect of the chemotherapy. So low blood counts causing bleeding, anemia, and infection. So these are things that we're quite cognizant of and we look out for during treatment for these patients. Late side effects include things like
It's 11 o'clock.
area, urinary symptoms, bowel effects, even sexual dysfunction, and most, well, we always tell patients about it, not most commonly, least commonly, but something that we have to be very wary about, is secondary cancers. So it's more so common in children, but we always inform our patients about such as radiation causing such.
Why not do the radiation after the operation?
So that's a very good question. Why not do the radiation after the operation? Luckily for you, sir, we've compared the two, given the radiation and the chemotherapy before and given it after. What we've found is that giving it before has a little bit of a better reduction in local recurrence rates, as you can see here, the penultimate thumbnail. In addition to that, importantly, giving it before has actually shown to have a better side effect profile than giving it afterwards. The disadvantages of just giving this neoadjuvant chemoradiotherapy is that sometimes we never know, the MRI may overstage, we might be overtreating very early tumors. And I always tell patients this when they come to me, we're giving it before, and I don't know if you know, when you have sphincter involvement, most likely you have a colostomy because of leakage and all these other symptoms. And the thing about it is some patients come hopeful that the radiation may cause sphincter resolution of disease, and therefore they can have reattachment of the bowel and no longer have a stoma. The thing about it is we never ever tell patients that we're giving neoadjuvant chemoradiotherapy for sphincter preservation. If it happens, it's a bonus, but the main thing is for local control or to reduce local regional recurrence rates. However, it may happen, but you never go in with that notion.
Why do I need chemotherapy with the radiation?
Right, so you're asking me, that's a quite feasible question. Why do I need this combination? So the benefit of chemotherapy has no effect on survival, which means that if you got it or you didn't get it, it doesn't determine if you're going to be alive at 5 to 10 years or not. However, the local control rates are better. And also with the chemotherapy, that even seen that when they go in and do the operation, what we call the pathological complete response rate or the tumor disappearing, those rates are higher. Essentially, we know theoretically that the radiation helps the chemotherapy, helps the radiation to work better. And it also can eradicate any micrometastases that you can't see with the naked eye. The usual regimens that the chemotherapists would prescribe include things like 5-fluorouracil and capecitabine. Capecitabine is feasible because it's an oral form, and therefore the patients don't have to repeatedly come in for infusions. This case is an 80-year-old lady who has a good performance status despite having things like diabetes, having a previous myocardial infarction. She actually is on warfarin for pulmonary embolism, but she's quite stern. She wants to stay in country. She actually doesn't want to get vaccinated for COVID, and she wants to get treated. So she wants best of both worlds. What is the next step in her management? So this is not quite common out here. It's something that's developing. It's called short course radiotherapy. So I want you to imagine this. If I were to put you out into the rain and it's lightly drizzling, in order for you to get soaked wet, I probably could leave you out for very long. Let's call it 25 days. If I put you out into the rain and it's heavily drizzling, moderate or heavily drizzling, you don't have to stay out in the rain that long to get the same effect as if it was drizzling quite lightly. So therefore, when we actually use short course radiotherapy, what we're doing is giving big doses. So buckets of drop sort of rain or doses. And therefore the overall treatment time becomes shorter. So it's just 5 days. So we're given 5 rays per day, whereas the conventional treatment, or what we call long course chemoradiotherapy, is a little bit every day, just that much to cause the cancer cells to be damaged and to allow for recovery. The thing about it is a number of radiation oncologists don't feel comfortable giving the big doses in just 5 days without being able to see what they're doing. So this picture below depicts that. This picture on the left is the CT scan that we would have used to plan the radiation as pilots. And this one on the right actually is a superimposed image on the day of treatment that actually shows you that you're treating what you need to be treating. Therefore, you can comfortably give big doses per day. Unfortunately, this is only available in the private sector in Jamaica. So in terms of the evidence-based medicine, the short course radiotherapy was in fact compared to just giving surgery alone. The Swedish actually saw an overall survival benefit, but the thing about it, or the nuance about it, was that they weren't doing the proper total mesorectal excision in that study. The Dutch came in and said, okay, we're going to do the total mesorectal excision. They did not see a major survival benefit, but they saw reductions in the 5-year local recurrence rates. Then the Dutch came 10 years later and said, okay, you know what? In the States, too, they actually have a survival benefit as well. So when does one use short course radiotherapy versus long course radiotherapy? So the two have actually been compared. So 5 days, 5 gray versus chemoradiation. Not much of a difference really, but what they found in terms of survival, that is, what they found is that if you give long course radiotherapy, you actually increase your chances of a pathological complete response, meaning that when you go in there and you take it out, you don't see anything. This study actually also supports that. But the thing about it is, in these studies, that short course radiotherapy was just given the radiotherapy in 5 days and then operating within 7 days. So basically, you're just rushing to get to the operation. Now, we conceptualize the reason for the radiation is to reduce local regional recurrence rates. But what happens if you were to give the short course radiotherapy and wait? So remember, we did say earlier that you have to wait for the cell to go through the cell cycle and die. So what we started to realize is maybe that the short course radiotherapy is not as good as the long course radiotherapy in terms of those complete pathological rates. It's just that we weren't given it enough time. So the Stockholm trial compared the 3 arms. They compared giving short course radiotherapy and operation shortly after, short course radiotherapy, and then waiting about 48 weeks and then operating, and then long course radiotherapy, sorry, which will be with chemotherapy, and then an operation. Not much of survival differences, but when they looked at the short course with a delay versus direct surgery, they realized that they had lower rates of post-operative complications when you delay, and also, of course, as expected, the greater tumor regression and complete pathological response rates when you delay. So we're going on to a case of a 30-year-old male who presents with T4 lesion. I believe it was a T4B with EMVI, splinters involved. It's just not a pretty case. He had a diverting colostomy, luckily, because we don't want him to have any of those symptoms of leakage. And we're trying to figure out what's best for him in terms of treatment. We're going to discuss him in the MDT. It's not an option here. But what would you choose? Upfront surgery, neoadjuvant chemotherapy only, short course radiotherapy, and an operation within 7 days. And remember, I said you were trying to actually make sure that your circumferential resection margin is clear before you go in there, or total neoadjuvant therapy. Now, total neoadjuvant therapy is new. It is a diverse term because you have different types. But let's see what option you choose based on what you know. So if you chose total neoadjuvant therapy, you're right. So NCCN, they're quite, pedantic, or they're quite careful in what they actually propose or recommend. As you can see here for T3, early end disease, or even nodal disease, sorry, they give you an option for total neoadjuvant or neoadjuvant therapy, and you can choose either or. But when you come to the advanced disease, the T4, where your circumferential resection margin is involved, they actually are quite stern and they say total neoadjuvant therapy only. That's the only option there. The Spanish GCRT trial was a trial that compared giving everything at once and then doing the operation versus giving chemo-RT operation and then chemotherapy. The Spanish realized that there was a better sort of compliance because these are the sort of combinations that you'd want to use in high-risk patients. They realized that there was a better compliance if you just gave everything at once and then operated and lowered acute toxicity rates with similar sort of outcomes. That means that what happened if you give the chemoradiotherapy, operated, and then try to give them chemotherapy after, the patients basically ran away. So the more sort of prominent trials when it comes to total neoadjuvant therapy are the Rapido and the Prodigy trial. The Rapido trial, just think rapid, they tried short course radiotherapy as the experimental arm, and then they gave chemotherapy and then they operated. And they compared it to giving the chemoradiotherapy, operating, and then giving high dose chemotherapy again. So it's like a sandwich. So in that trial, they used short course radiotherapy only. And the similarity or the dissimilarity was that in Prodigy, they actually used long course radiotherapy and started with the high dose chemotherapy, moved on to the long course chemoradiotherapy, and then did the operation and then even tried chemotherapy afterwards. Now, the thing about it is in that trial, the endpoints in terms of disease-related treatment failure and disease-free survival in the case of the Prodigy trial were quite significant. The pathological complete response rates were significant as well. So they got what they expected to see. But something peculiar happened. The local relapse rates were higher in the experimental arm in the Rapido trial. Why? Well, one person proposed that perhaps the chemotherapy that they give after they gave the short course radiotherapy, being 18 weeks, may have been a bit too long and would have caused the clones that were sensitive to the radiation to regrow. That's one postulation. So they have now developed a modified chemotherapy protocol for the Rapido trial. But what do we start with? Do we start with radiation? Do we start with chemotherapy? Where do we start? So the Opera trial, that's a peculiar trial in that they are just trying to see who they can get organ preservation for. But what they did was one arm, they started them with the chemoradiation and then gave them the high dose chemotherapy. And in the other arm, they started them with the high dose chemotherapy and then gave the chemoradiation. So they flipped it around. And the outcome of that was that those who started with the chemoradiation and then went on to the high dose chemotherapy before any sort of other surgical intervention were more likely to have a TME-free event, meaning that they didn't really need operation. The CAO-RO trial, they compared the chemotherapy, they flipped it around as well, and they actually saw similar outcomes. But the thing is, what they said was the pathological complete response rates were higher in those who got the radiation chemotherapy before they moved on to the high-dose chemotherapy. In addition to that, the complications were a bit lower. So the approach, though, for any patient should be trying to pull from all angles. NCCN says, you know, stage 2 and stage 3 rectal cancers, they should get total neoadjuvant therapy. In our setting in Jamaica, it's quite feasible because what happens is radiotherapy dates are not that accessible or readily available. And you can start these patients off on the high dose induction chemotherapy whilst they wait radiotherapy, they get radiotherapy, and then they can move on to their operation. So we have a 50-year-old male who presents with a low rectal cancer. He has a bit of nodes. And in addition to that, unfortunately, they found a liver lesion, but the hepatobiliary team believes that it's resectable. No, I asked someone this question previously, and you know, I could tweak it a little bit to make you understand why I would have chosen my option, but you can choose your answer in your heads. Starting with short course radiotherapy. Now, firstly, just to reiterate, short course radiotherapy is never, if I haven't before, it's never given post-operatively. And when you come to these patients with oligometastatic sort of resectable disease, you have to look at the husband and the wife. So the husband is the primary and the wife is the metastasis. So you have to see what the husband is doing and what the wife is doing. So if both are resectable, there is an option to move directly to an operation, and then you can give chemotherapy afterwards, as the Leeds Teaching Hospital has depicted here. However, if you have high-risk features in the primary, but the circumferential resection margin or the garbage bag isn't affected, ideally you should be given short course radiotherapy to reduce those local regional recurrence rates. And then what you can actually do is move on to an operation for both. So the beauty of this here is that if you have high-risk features, you can get in the radiation quickly in just 5 days and address your metastases quickly. Because what can essentially happen, and you'll see it in a later slide, is that if I were to try and give the long course chemoradiotherapy, let's call it 5 weeks, and then you're going to wait for the operation, there is a possibility that you can be given the radiation to the primary is doing well, but the wife is upset. And the wife is getting bigger. I shouldn't have said that. The wife is actually becoming unresectable, or the metastasis is becoming unresectable. So the thing about it is you have to make sure that you're actually addressing the two of them and giving them the same attention. So if it is though that there are high-risk features in the primary and the circumferential resection margin, or that garbage bag is involved or burst, giving chemoradiotherapy and allowing for the time for the regression of the disease is not wrong, but what a lot of oncologists, especially in the UK, are concerned about is the dose of the capecitabine or the 5-fluorouracil that you give with the radiation may not be strong enough to cause regression of the metastases whilst you're giving the radiation. So in this instance as well, they say, give the short course radiation just 5 days, get that out of the way, and then you can move on to high-dose chemotherapy that will target both the metastases and the primary, and then you can possibly do a synchronous resection of the liver metastases. If they're both borderline resectable, there is an option to give the short course, get it out of the way, get the radiation out of the way, and then you give the neoadjuvant or the chemotherapy to see if you get a response, and then you can see what can happen afterwards. So in summary, I just want to in summary, the PR approach must be used for any rectal cancer patients, and all patients should be discussed in an MDT setting to get the best trajectory of disease or regimens. In terms of neoadjuvant chemoradiation, it improves oncological outcomes in regard to local control and has been shown to have a better side effect profile in comparison to giving it after the operation. Long course chemoradiotherapy has been shown to have a greater pathological downstaging effect, but higher early radiation toxicities. And that's possibly because it's used in combination with chemotherapy in comparison to the short course with no delay. However, when you compare the short course with no delay with the short course with delay, you realize that allowing that time has been shown to lower rates of post-operative complications and greater tumoral responses, or increased rates of greater tumoral responses. Total neoadjuvant therapy is preferred by NCCN for stage 2 and stage 3 disease, but you can tailor it to your setting. Short course radiotherapy becomes crucial in the management of metastatic disease, as it can easily allow for control of local disease and urgent management of the metastases otherwise. And as you can see or to reiterate in the previous vignette, the old lady, you would have seen that it can be used in logistically feasible settings. I mean, in the event of COVID, even in North America, a lot of centers, in order to not have patients repeatedly come in and reduce transmission rates, actually propose that short course radiotherapy be the primary treatment for rectal cancers, especially in the center where I trained in South Africa, that became the norm. So therefore, there are things that you can do to tailor to your setting. Having a resource depleted setting is not always, a train smash. So in terms of my resources, these are the few. I would like to thank the Jamaica Cancer Society for having me. My place of practice, the Kingston Public Hospital and the St. Joseph's Hospital, the Radiation Oncology Center of Jamaica, and the Leeds Teaching Hospitals and the Tata Memorial Center at Kolkata for the slides and for the information. Thank you so much.
Thank you very much, Dr. Pemberton. That was quite interesting, and we realized you had your own Q&A within your presentation. Very, very interesting there. before I move on, both yourself and Dr. Peters stressed the MDT meetings. Can either one of you address then for the others out there, how do we go about getting the patients into these meetings? Who do we call? How do we get them shunted into these MDT meetings, which are being so stressed? Or is it based on particular institutions? KPH has one, UE has one, Cornwall has one, just for the broader set. Can one of you just address that? Yeah, you're muted. You're muted if you're Dr. Pemberton.
You hear me now?
Yes.
Yes. So KPH has an MDT at least once a month where we do discuss rectal cases. The University Hospital has a weekly MDT, and as the rectal cases come along. So it's a general oncology MDT, but the rectal cases can be discussed there. With increased staffing and with increased resources, we do envisage that we would be able to have weekly rectal MDT meetings with, of course, the specialized colorectal surgeons, making it a bit, cohesive, holistic, and many points of view, so that we can actually, create a national guideline eventually, or national guidelines or protocols eventually. So we're getting there. If you wish to add a patient, Dr. Simpson at KPH, he's a good person to contact. And of course, Dr. Sheree Chin at the University Hospital tends to spearhead the MDTs.
Okay, and Dr. Peters, is there one at Cornwall?
So not currently, but I think it's something that was there previously. So it's just something to start back again. I'm not aware of one right as we speak now.
Okay. Thank you.
All right, thank you.
Dr. Pemberton, there's a question for you here in the chat. What is the time interval between the end of neoadjuvant EBRT and surgery resection? Question from Dr. Mullins. You're muted, Dr. Pemberton, you're muted.
It's of course setting based. Of course, if you're using short course radiotherapy, 6 to 8 weeks. Neoadjuvant chemoradiotherapy can be 10 to 12 weeks. The thing about it is you can also now do what we call an MRI, or we call a tumor regression scoring MRI, to see what type of response you've gotten from the radiation. It hasn't been happening here any at all, but a number of the first world settings are also trying to lean toward organ preservation. So therefore, it is not quite set in stone. It is set in base and according to what type of neoadjuvant treatment you've used.
Okay. And there are no more in the chat, but I would just quickly ask the last one. You mentioned that the short course radiotherapy is only available privately. That is roughly cost-wise how much in the event that needs to be worth?
So the operational cost of radiotherapy privately are exponential. I quite don't know the cost, unfortunately.
Millions or hundreds of thousands?
It's around the millions, I believe.
Millions, okay.
The thing about it is a number of patients tend to fare better if they have access to health insurance. And if you look internationally, it is quite expensive when you do the conversion to the US dollar. Operational costs do entail, electricity. We have team members, the radiation therapists, and we actually have someone called a medical physicist or dosimetrist or a dosimetrist who actually does the planning. So it's all hands on board. It's a sort of papillary, well-integrated system that tends to not be apparent to the patient. The patient sees a doctor. So it's quite easily mistaken for being expensive, but you have to be cognizant of the operational cost behind it.
Okay. All right. Thank you. Thank you very much, Dr. Pemberton, for that. This is very interesting, several very interesting talks happening this morning. I'm very, very happy about that. At this point, we're going to have a brief presentation from one of our sponsors about nutrition by Mr. Paul Russell, followed by a quick video from AA Laquise. could just proceed, Mr. Russell. Yes. Not hearing you, Mr. Russell. Okay.
Yes, I'm saying hello. I'm going to go to my presentation at this time.
Okay.
Share screen. Are you seeing my screen?
Yes, we are.
Okay. Good day. As mentioned, my name is Paul Russell from Abbott Nutrition, and I'd like to thank the Jamaica Cancer Society for the opportunity to present at this year's Colon Cancer Medical Symposium. Today, I'm speaking on Vital 1.5 Cal, which is a peptide-based therapeutic nutrition drink, which provides complete balanced nutrition for patients who are experiencing malabsorption, maldigestion, and impaired GI function and GI intolerance. Vital 1.5 Cal contains advanced blend of hydrolyzed protein, structured lipids, and prebiotics to support absorption and tolerance. And it is a calorically dense presentation with 355 calories in 8 fluid ounces, or 1.5 calories per mil for fluid restriction patients. It contains elevated levels of antioxidants, vitamin C, E, and selenium. And as I mentioned before, it has structured lipids, which are the next generation of fat made by the re-acidification of medium chain fatty acids and long chain fatty acids on the same glycerol backbone. So this new hybrid molecule, which is called a structured lipid, provides a combined benefit of long chain and medium chain fats on the same molecule. So this structured lipid is able to be easily absorbed. It bypasses the liver and provides much needed energy in the peripheral tissues. And this is particularly useful in the patient that has an impaired liver. I may also take the opportunity to remind on the Ensure line of products, just needing to find the right or ideal Ensure to help your patients reach their nutritional goals. And for your patients living with diabetes, I want you to recommend Glucerna as part of their diabetes management plan. The products are ideal as part of a meal or a snack. I've taken the opportunity to also include my business card, and I can be contacted by cell at 489-6093 or by email at paul.russell, and this Russell is spelled with one L, at abbott.com. Should you have any questions or queries regarding any Abbott nutritional product, I'll also take the opportunity to put my contact numbers in the chat. So should you want to ask any questions, I'm readily available for that. I thank you again for the opportunity to present.
All right. Again, thank you very much to our sponsors. I now have the pleasure of introducing Dr. Smith, who is a general and colorectal surgeon at Kingston Public Hospital. He did his DM surgery and his MBBS at the University of the West Indies with a clinical fellowship in colon and rectal surgery at the University of Toronto. Apparently, he's an avid football fan and a football dad, and took his Sunday to speak to us today on colon cancer screening and the surgeon's perspective. A very, very prudent topic. Go ahead, Dr. Smith.
Thank you, Krista K. Good morning to everyone. I'd like to first thank the organizers of this annual symposium for inviting me to give a talk. And so thank you. Hopefully it's informative. All right, so you're seeing my screen and hearing me, so I think we can begin. This is just a reminder that not all cancers are pink. When I think of colorectal cancer screening, I try to look at what the problem is first. And we have some data. I'll go back as far as 2003, 2007, where you can see the age standardized ratio was about 17.2 per 100,000 for men and about 12.8 for women. So we have data going back before that, but I went as far back as that. And at that time, what you could see was that large bowel cancer was the third most common cancer in Jamaica, from the cancer registry at the University Hospital. Now, when we move to 2020, has anything really changed? The colorectal cancer, in terms of new cases in 2020, with figures from GlobalCan, remained our third most common cancer in terms of new cases, behind breast and prostate cancer. When we break it down into males and females, there's a little change. I compared 2018 to 2020, and you can see that in 2018, new cases of colorectal cancer was a third compared to 2020, where we had an increase in the number of cases and it became second only to prostate. While in our women, it was second in 2018 with 573 new cases. And we had some improvement in terms of new cases in 2020, with it falling all the way to fourth. So this is just a graphical representation of those figures. Now, there were no figures to show where Jamaica stood, but the Caribbean on a whole, when you compare them to our North American counterparts in terms of incidence rates, you see we were about, in the Caribbean, 18.5 for men, 17.8 for women, compared to someplace like in North America, where you can see their incidence is much higher than ours, 23, 29. But the important thing that I want to point out in this slide here is that when you look at our mortality rates, you can see our mortality is 10.4 compared to 10.4 per 100,000 compared to our North American counterparts, where even though their incidence overall is much higher than ours, their cases seem to be doing much better. Let's progress. How our cancer patients doing as a follow-up? As early as 2004, Professor Mikey McFarlane looked at our patients and found that 36% of our patients presented with a Duke C carcinoma, while 23% had metastatic disease. Professor Plummer, once again, some 12 years later, looked again and found that 43% of our patients had stage 3 disease, while 27% already presented with metastatic disease, and our 5-year survival overall was about 33%. which doesn't bode well for us given those figures. So I know somebody from MOH will be presenting after, but as far as I'm aware, there are no national screening program exists at this point in time. And so we have a long way to go. I always like to say, why screen? Colorectal cancer is preventable. We know this. Early cancers are usually asymptomatic, and the 5-year survival for stage 1 disease is over 90%. And this is without the necessity of receiving chemotherapy. We know in places where there's established programs, like the SEER database, new cases fall on average by 2.6% per year. Death rates have fallen also. And we see that there's improving in survival once we have a screening program. Now, there's several guidelines, I think, that are available for anyone. You can look at the National Comprehensive Cancer Network, Cancer Care Ontario, the US Preventative Task Force. You can even look at Europe and their Society of Medical Oncology, and the American Society of Colon and Rectal Surgeons. That was last updated in 2021. This slide just shows a summary of the US guidelines. And importantly, if you look, you can see that there is some variation in the age to start screening for the average risk person, but they look at the majority of tests that are available: FOBT, FIT, flexible sigmoidoscopy, virtual colonoscopy, standard colonoscopy. And there's some variation in the timing of these tests and how often you do it, but the majority of them are usually consistent. Now, if we look at around the world, screening tests that are recommended and the preferred method varies. Because if you look at North America, they tend to primarily do colonoscopy. Although I would say that in Canada, the primary starting tool is not a colonoscopy. You look at the UK, Europe, some areas, FIT would be the starting tool in terms of screening. And so it varies from region to region. If you look, there are local guidelines published in WIMJ, and locally, the recommendation from the university is to start screening the asymptomatic patient at age 45. And it looked at the different tests, FIT, annual FIT, FOBT, colonoscopy, and made recommendations as to how we should go forward. This is a summary of the Ministry of Health and Wellness screening guidelines, and I'm sure they'll go through more about it, so I will leave that here. Now, when I'm talking about screening, I'm mainly focusing on the average risk group. There was a strong recommendation to start at age 50, but there's been a change recently. And that started probably in about 2018 with the American Cancer Society giving a qualified recommendation to start at age 45. Generally, when I speak to the medical students, I remind them that you can break it down into 2 sorts of tests: stool-based tests, fecal occult blood testing, fecal immunochemical testing, stool DNA, and the structural tests you would see is flexible sigmoidoscopy, colonoscopy, and CT colonography. I will say that barium enema is not usually recommended as a screening tool. If we look at FOBT, which is quite popular and done by all labs, I would say, in Jamaica, there's still dietary and medication modifications. Usually 3 samples are needed. And it's quite sensitive for blood, but how specific is it? Patients generally who have a FOBT that is positive, the recommendation is usually that they proceed to a colonoscopy. Now, FIT, that's a bit more sensitive than FOBT for adenomas and cancers. And the patients are more likely to comply because it's only 1 sample that is needed. And the evidence supports that this, in terms of them being more compliant with staying with a screening program. And FIT looks at human globin specifically. The new kid on the block in terms of stool test is stool DNA, which is Cologuard. That's another name for it. There's limited data, and the usual recommended interval is about 3 to 4 years. Now, the problem with stool DNA, the issue is that it can give a lot of false positives. And that, as you know, can cause unnecessary worry in patients. So hopefully, as more and more data becomes available, we will have more guidance on the utility of stool DNA or FIT DNA. The other two looking at the structural tests are flexible sigmoidoscopy. And we have randomized controlled trials and meta-analyses, which show that it reduces the incidence and mortality for colorectal cancer. And so flexible sigmoidoscopy remains a very good option. The newer kid on the block, replacing barium enema in my estimation, is a CT or colonography or virtual colonoscopy. It's a non-invasive technique, mainly. It's evolving. There's a dilemma because the issue with CT colonoscopy is that it can pick up extracolonic lesions. And do we now open another can of worms for a patient? Smaller lesions tend to be missed, less than 6 millimeters. And what do you do with a polyp? Right now, the recommendation is once you find a polyp, the patient gets a colonoscopy. But is that the polyp that is going to become a cancer? So that's the recommendation. And the reality is that you still need to do a CT colonography once that is your screening method every 3 to 5 years. The other kid on the block is a colonoscopy. Now, when we speak about screening and I ask the question, colonoscopy is usually the first test that is recommended, that is answered. And I ask why? And it's the gold standard. And is that really so? There are no published randomized controlled trials. They are currently ongoing. So why is it that we think colonoscopy is the gold standard? Recently published, I believe it was October of 2022, was a trial from Norway. And that brought colonoscopy into question because it said that, in summary, that there was maybe no benefit, but there were a lot of issues with that trial. And in terms of the amount of patients that decided to undergo a colonoscopy. So we are waiting more evidence. We know that there are ongoing randomized controlled trials, and hopefully that data will be published shortly. What we do know about colonoscopy is that it does make some sort of difference. From a Rabinek in 2010, 2.4 million people. And every 1% increase in the rate of colonoscopy led to a decrease in the risk of death. There are certain things about a colonoscopy we have to keep in mind because not every colonoscopy is the same. The quality of bowel prep is a consideration. What is your endoscopist cecal intubation rate? Are they getting all the way around the colon? Are they looking in the cecum? What's the adenoma detection rate? And the lower the adenoma detection rate for the endoscopist, it's usually does not suggest that you're getting a quality colonoscopy. What is the withdrawal time? The surveillance intervals, and that depends on whether it's a normal colonoscopy or not. And generally, the recommendation is somewhere between 7 to 10 years. And colonoscopy is not without complication. I don't think I can say that loudly enough because I've had patients who come and when we discuss in terms of consent and I tell them about the complications, which is perforation, and the perforation rate is not high, but I've had patients who now come and say, oh, if I knew this was the story, I wouldn't have come to do this. So I think patient education in terms of the test is quite important because it's not really a benign procedure. And somebody who taught me once said that there's nothing to humble you like a colonoscopy. You think you're good, and then you'll find one that really reminds you that anything can happen. This study by Professor Lee, which looked at colon cancer screening, the knowledge and attitudes in the Jamaican population and physicians, I find quite instructive, because when they asked the general public, a lot of patients said either they never heard about colorectal cancer or they did not know enough. Very few thought that they knew enough. But the majority of our patients thought that if they were adequately educated, that they would, informed of the disease process and what they're doing, they would seek screening. When we looked at physicians, 89%, which is great, feel that a screening program is necessary. And this is from 2017. We start getting fewer numbers, because going to almost 50-50, where our physicians discuss screening some of the time. At that time in 2017, when it was published, 82% would recommend a barium enema for their patients, and 72% would choose something differently for themselves. And I think that speaks for itself. What are my thoughts at this point in time about screening? I think we definitely need a national screening program. Education is quite important, and that we should all be screening commencing at the age of 45 years. I think that FIT should be our initial test, followed by colonoscopy. We just don't have enough endoscopists. And so for a national screening program, FIT should be our test. Until that happens, I think that we all owe our patients a sit down in terms of talking and going through the pros and cons, because when I ask what the best screening tool is, and I get certain answers, I kindly remind the residents and the medical students that the best test is the one that the patient will do, because we want compliance. We need to train more endoscopists. So as part of our DM programs at the university, should endoscopy be part of general surgery training? We need more endoscopy equipment. The equipment at the Kingston Public Hospital recently returned from being fixing, and the demand is there because we are already booked out probably until July already, and we've only restarted within the last month. And we do need more data. As you can see, published locally is a lot of retrospective information, and they're still quite old. So hopefully we will start to improve and do better, because screening is quite important. That's the end of my presentation. Thank you very much. Any questions?
Sorry about that. Thank you, Dr. Smith. Well said. And I completely agree with pretty much all that you've mentioned here. The last point to reiterate is that any test is better than no test, to be honest. Another thing too, just to point out, a lot of the patients, they will go and do their executive, and in their executive, you will get the fecal occult blood test, and most of them, they do one. You did mention, and rightly so, that ideally they should be having 3 fecal occult blood tests done. There was one question here that I put to you. If a polyp is found anywhere along the GI tract, including the gallbladder, should a colonoscopy be done?
It depends on whether they have a genetic syndrome, that the gallbladder will be a completely separate entity. Sometimes patients can have polyposis syndromes, and that will determine how we will approach them. I've seen quite a few patients who would have a family history of cancer, and the recommendation is to go straight to screening. And sometimes I think a little bit more time should be spent in discussing that family history and going in and maybe and offering genetic testing, which is offered locally, because it's not just about that patient, it is about their family as well and their offspring. And it has to be some sort of systematic approach to determining whether they are going to be average risk, whether they're going to now be at an increased or high risk for developing cancer, and how you approach that patient as well.
Okay. And you mentioned colonoscopy withdrawal times by the different endoscopists. There's a question here asking what is considered the ideal time for withdrawal.
I think before it used to be 8 minutes, so it does take some time. I've seen more recent publications that said 6 minutes. So I think that is 6 to 8 minutes is fair enough. I know routinely, if you at university, one place, once you reach the CCOM, they start the clock. And so you kind of know that, all right, am I moving too fast? And that's the important point, the important part of the colonoscopy. I tell you, half the time, I'm just trying to get to the end. I'm just trying to get to the end and safely get to the end. And if it is that's my concern, I'm going to miss things if I'm trying to, so the withdrawal time is important. And so I just make that part where I'm so happy also that I've gotten to the end that I was like, okay, good. Let's take our time and see what's happening here. The smaller polyps, if I come across a small polyp and I'm afraid that I will miss that in withdrawal, I'll deal with that at the time. But the specific time for looking would be on the withdrawal.
Right. And speaking on that, in terms of starting the clock, where I was trained as well in Canada, they would withdraw from the CCOM and get to the transverse colon and go back to the CCOM again before coming. Mind you, not everybody does that, but just to ensure that nothing is missed, because the right-sided lesions really do tend to be.
Yes, actually, I've seen that that recommendation. So double intubating, getting back into the transverse colon and looking again improves outcomes. So yes, I've seen that as well. Okay.
And then kind of to go back a little bit, there was a question before about the time interval between neoadjuvant EBRT and surgical resection. Dr. Pemberton had answered, I think this is Dr. Mullins, made a mention about being concerned about the amount of scarring from neoadjuvant RDT at surgery, and so concerned about ideal timing. Dr. Pemberton had answered here in the chat, saying that the time isn't quite clear, at least by experts, but different surgeons may have different thoughts on it, I guess is where this is, and it depends on trials and clinical experience. This is kind of sidelining because you weren't talking about radiotherapy, but just because you're a colorectal surgeon, I'm just wondering if there's a specific time for you and radiotherapy at surgery to answer Dr. Mullins' question.
I agree with Dr. Pemberton in terms of the timing for surgery. I find in terms of scarring, sometimes that's hard to predict, but we sometimes tend to use our old cobalt machine. And I think that's where we do find that there is scarring. The use of the linear accelerator, definitely those patients, I do see that there's an improvement, but it's not predictable a lot of the times. I think it's definitely with the linear accelerator, we're seeing less, and it's usually an easier operation than with the older cobalt machine.
Okay, thank you. And another question now on your topic, how do you manage multiple colon polyps?
I think that's a judgment on what is available. Pedunculated polyps pedunculated polyps. Some of them are quite easy. It's just a snare and a snip. Some of them are a little bit more challenging. The flatter ones, what I would say is that the important thing is never be afraid to ask for help. In fellowship, we were lucky. There were things that the gastroenterologists were right across the room. And so this is where I would say, and they advanced gastroenterology fellowships and all of these things, they can come and they will assist you, especially with, and a lot is needed, especially for the bigger polyps, especially the flat ones that you might, not just lifting them, but at least being comfortable in the defect that you've created. And so I have no issues in terms, thankfully, we do have an advanced gastroenterologist back in Jamaica, and I have sent a few patients to him, Dr. Fairclough, so that he takes them out. Because I think importantly, once he's able to remove them, we can save and you'll say it's strange to hear this, but we can save the patient an operation and they can keep their colon. And so that's the important part. It may not be necessary because colorectal surgery does have complications. We can have leaks, which can be horrific for the patients. So it is choosing what the right approach is. And so the important thing is, if you can't manage it or you don't feel comfortable, there's no harm in sending it on to somebody else and use your colleagues for advice and balance.
Right. Okay. And Dr. Mike Mills has, well, he says he has many comments, but he'll make one at this time. And that is the data always shows that using stool tests for population screening will increase the colonoscopy rate. So no doubt there is a need for well-qualified practitioners, right? Good point.
I couldn't agree with that comment more. We do need more. And so right now, I think the only hospitals doing endoscopy publicly are KPH and University Hospital. Yeah. That's definitely not enough.
Definitely. I won't go into University Hospital wait times at this point. That's not what regular.
And it's the same. Shortly at KPH, I'm sure we'll be at the end of the year.
Yes. Yeah, it is. Okay, thank you very much, Dr. Smith. Very informative again.
Thank you once again.
All right. Our next presenter is going to be Dr. Davidson. Dr. Davidson will be speaking to us on behalf of the Ministry of Health and Wellness. And she is a director in non-communicable diseases and injury prevention at the Injury Prevention Unit, and she specializes in public health. She will be talking to us today on the Ministry of Health and Wellness screening guidelines for colorectal cancer, which I'm sure will garner a lot of questions here. So looking forward to this talk. Please go ahead, Dr. Davidson.
Hello, everyone. It's a pleasure to be here. I'd like to thank the Jamaica Cancer Society for inviting us to present at this seminar today. I will now share my screen. So just give me a moment here to share my screen. So I'll be presenting today on the National Screening Guidelines for Colorectal Cancer for Primary Care by the Ministry of Health and Wellness. The outline on the presentation I'll be looking at today will look at the status of colorectal cancer in Jamaica. I'll talk a little about screening and introduce you to the National Screening Guidelines for the priority NCDs, and then go through some of the key elements of the screening guidelines. So in terms of the status of colorectal cancer and NCDs in Jamaica, we know, and many of you have seen this data, that NCDs are the leading cause of death and disability in Jamaica, and cancer accounts for 20% of this. With respect to colorectal cancer, 1 in 9 of all new cases are due to colorectal cancer. It's the 4th leading cause of death, and the third leading cause of death amongst men and second among women. And the highest age group affected by colorectal cancer with respect to mortality is the 60 to 64-year-old age group. So what is screening? So we're going to be talking about the screening guidelines, but what is screening? And screening here, this is a definition from the World Health Organization, is a presumptive identification of unrecognized disease. So in an apparently healthy asymptomatic population, so persons who have no symptoms at all, and it's done using tests, examinations, or other procedures that can be rapidly applied to the target population. And so basically screening is like a sieve. When you apply these tests, identifying who may have a disease or a health condition and who may not. So why do we screen? And these are some of the main reasons for really having a screening program and screening. And that is really, we want to reduce death and disability. We want to be able to detect the disease early, in its early stages, where we can do something about it, either lead to a cure or treatment of the condition. And we want to be able to also prevent new cases by identifying the precursors of these conditions, and also identifying the risk factors. We also want to reduce the severity of these conditions. So we want to really offer timely treatment, effective treatment, timely diagnosis, and we want to increase the choice by identifying conditions or risk factors at an early stage in the life course. So the Ministry of Health developed in June 2020 a national screening guidelines for priority NCDs in primary health care. This was the first guideline of its kind that the Ministry of Health had developed, and in the Caribbean in and of itself. It covers the 7 health conditions listed here, and colorectal cancer is found in Chapter 7. This guideline was developed by working with our key experts using the GRADE methodology for evidence for developing these guidelines. So how do we use the guidelines? The guideline is a guide, of course, and during the patient encounter, the healthcare provider will use this. There are 3 key things that they'll use, approaches to using the guideline. And one is the healthcare provider will need to identify the patient's age and stage along the life course. And life course, we're speaking to the different stages from what we call the womb to the tomb. And I will show the groupings for the life course that we have with respect to this guideline. And then after having done that, you classify the patient based on their risk into average and high risk based on the NCDs for which you're looking at. And in this case, we'll be looking at colorectal cancer. And then we identify the recommended screening tests for the patient appropriate to their life course stage, age, and risk classification. So with respect to the life course, there are 3 groupings here with respect to life course stage, generally for the screening guidelines listed here. And we see adolescent, adults, and elderly age group. So for colorectal cancer screening, one of the things that we'll look at first is the risk assessment. So we classify the patient according to their risk for colorectal cancer. And the risk would be average risk and high risk. And here, average risk the patient would fall in that category if they're asymptomatic adults 45 years and older and younger with no family history of a genetic disorder that predisposes them to this lifetime risk of colorectal cancer, and if they have no associated risk factors. However, they fall in high risk if they have these conditions listed here, along with a family history of polyps and colorectal cancer, along with an adult with a history of known genetic predisposition to high lifetime risk of colorectal cancer. And here are some such as Lynch syndrome. And then if they're over the age of 50 years, they would fall within this high risk category shown here. So in terms of the screening test selected, this will be determined whether they're fall in the high risk or the average risk category. So these are the screening tests that are recommended within the guideline. And these screening tests for early stage to detect early stage colorectal cancer are stool-based tests. Here you have your FIT, your FOBT, your fecal occult blood test, and your FIT DNA. You also have your direct visualization tests, such as your flexible sigmoidoscopy. And you also have your CT colonography, which is the virtual colonoscopy. The FIT test here has the highest yield, and the colonoscopy has the highest sensitivity. Currently, the FIT DNA test is not recommended for population-based screening. And then we also have the CT colonograph, which is considered to be used only in selected cases where its colonoscopy is contraindicated, not accepted, and should not be a substitute to the direct visualization test. So these are the key tests that are recommended under the screening guidelines. Another special consideration for colorectal cancer screening is the age, where you're 76 years and older and you've never been screened. You may be offered screening if you're in good physical state, that's the recommendation, and free from significant comorbid conditions. So here, a risk-benefit analysis should be done. The screening option should be discussed with the patient, and there really should be a low threshold for consultation and referral to the specialist clinic. The evidence does suggest, in general, that starting at the age of 45 years old, in our Jamaican population, where over 90% is of African descent, that we should start at this age. So this is something to highlight in applying the guidelines. So here we will now go through and look at the screening for colorectal cancer in keeping with the life course and what are the key recommendations. And here we will go through from adolescence to late adulthood. So when we look at screening in the age 10 to 19 years old group, we look at health promotion and prevention is going to be an important element. So here we are recommending in our guidelines that education on colorectal cancer and risk factor reduction is going to be an important element. And these can be done within your primary healthcare facilities, within your private practices, in the community setting. And it could be done in schools, in faith-based organizations, during our public health campaigns, and also part of our mobile outreach. So education around colorectal cancer and risk factor reduction would be important. However, for the average risk, routine screening is not recommended in this age group. For the high risk, those are those adolescents with familial adenomatosis polyposis. Screening here would start at the age of 12 years old with colonoscopy. And so all high-risk individuals, however, should be referred to a specialist clinic. So when we now look at the 20 to 44 years old age group, similarly for health promotion and prevention, again, we emphasize the need for education on colorectal cancer for this group, and also an emphasis on risk factor reduction. And again, these interventions can be applied in a community setting, at a primary healthcare facility, in a private office, GP office, and in different settings, schools, workplace, and faith-based organizations. And of course, through our outreach, mobile outreach programs that we may have. So in terms of screening and early diagnosis, again, for the average risk, routine screening is not recommended. For the high risk, however, screening is recommended in patients with certain genetic disorders, such as your hereditary non-polyposis colorectal cancer with colonoscopy and referral. So here the test of choice is colonoscopy and referral to the specialist clinic. In the 45 to 74 years old age group, again, we emphasize the similar interventions again with respect to health promotion and prevention. So you can see the recurrent theme, the importance of right through the life stage, and emphasis on education about colorectal cancer and risk factor reduction in these settings. So in terms of screening and early diagnosis for the average risk, screening with the stool-based test is recommended yearly, and these are the two tests recommended. And if the stool is positive, then the next stage is to refer for the colonoscopy. So if colonoscopy positive, you refer to the specialist clinic, and if negative, you repeat for 10 years. With respect to the stool test, combined with the flexible sigmoidoscopy, can be used for screening instead of colonoscopy. However, then the frequency of the repeat test would be done every 5 years. And also for the FOBT stool test, it's important to emphasize that this stool test will need to consist of 3 stool samples taken on different days. And there is also a need to do the prep in terms of your diet, and at least 2 days before sample collection to avoid these items. So red meat, beets, carrot, broccoli, grapefruit, and that are listed here on this slide. So when we look at the high risk within this age group, the screening with colonoscopy is recommended, and if positive, then referral to specialist clinic. So if there's a negative screen, then you rescreen within 5 years, depending on a risk assessment or plan of care established with a specialist consultant. If colonoscopy is contraindicated or not accepted, you consult with a specialist and consider the CT colonograph or the virtual colonoscopy or a direct referral to the specialist clinic. Again, this should be done in consultation with the specialist. Follow-up screening should be based on the risk assessment, again, or a plan of care put in place by the specialist. All patients within this age group, regardless of risk assessment, may be offered colonoscopy as an initial screening test. So that is something we want to emphasize. So with respect to those 75 years and older, again, for health promotion, again, a recurrent theme right throughout the life stage is that education on colorectal cancer would be important, and the risk factor reduction. So again, this is done right through the life stage in these settings mentioned before to address the health promotion and prevention aspects. So with respect to screening and diagnosis, routine screening in this age group is not recommended. And if a clinical decision is made to screen, then the preferred modality should be via colonoscopy. So screening is most appropriate for those that are healthy, again, mentioned earlier in the presentation, enough to undergo treatment and without comorbid conditions that really significantly limit their life expectancy. So these are some of the things that need to be considered if we're going to recommend screening in this age group, but routinely should not be recommended. So this is the summary which can be found in the guidelines. of the algorithm for screening and follow-up of adults at average or high risk. And here, looking at average risk for those patients that are 45 years of age. And this recommendation also looks at the symptomatic or high-risk patient. And here you see the flow chart gives a high-level summary of what we had discussed earlier on with respect to screening with a stool test, and whether the result is negative or positive will determine the pathway that you will take along the screening line here, and which tests will be done. And here you can see a summary again of what was mentioned in terms of risk assessment for colorectal cancer, in terms of average risk, who would fall within average risk and high risk. And so it's important that we elicit this information in order to categorize a patient into average or high risk, and then to look across the life stage to look at which recommendation would apply in terms of which screening tests would apply for each age group throughout the life stage. So that summarizes gives an overview of the national screening guidelines. And these are just some of the posters and some of the material that we have done in our campaign, utilized in our campaign last year to raise awareness about screening, about colorectal cancer as a part of our health promotion and prevention interventions, and risk factor reduction, highlighting some of the key risk factors for colorectal cancer. The Ministry of Health has a comprehensive program which addresses the risk factors throughout the life stages, as well as promotes screening through many of our programs. And one most familiar to you is the Jamaica Moves program. And so here we also have a link to a video on Instagram that was posted last year on our Colorectal Cancer Awareness Month video. And this is, I invite you to go to this link and view this video, and also visit our website for more information.
I am not afraid to check out my colon. Preventative screening can prolong my colon. Come in if you care, you go get your colon tested. I do that long time, sweetheart. What? It's safe to say that I'm safe. Dada, you know the symptoms of colorectal cancer? What are the risk factors? All right, you're not paying me no mind. You go Google it. No, don't Google it. NC Dip It. Do wanna? The Ministry of Health website. NC Dip It. www.ncdip.moh.gov.jm, sweetheart. It is so easy to use that a old man like me can navigate the website with by pang, 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 pang. ncdip.moh.gov.jm. You will get all of the information that you need right on the website so that you're not so behind, my dear. No colorectal cancer can enter my colon. With early detection, I can hold on to my colon.
And thank you once again, Cancer Society, for having us here today. These are just some of the references. And I'd like to thank you again. All the best for the rest of this seminar. Thank you.
Thank you very much, Dr. Davidson. I've seen that video before and I laugh every time. Okay, just to address a couple of the questions. Well, before I get into Dr. Mills's question, there was a concern about whether these educational ads, for instance, that video, will be something that would be put in traditional media to be made available for more people to see.
Yes, certainly. That's something that we would do as one of our next steps. But yes. So we use multiple platforms to reach our target audience. But that's something that would be ongoing education, not just for the month, but ongoing education.
Okay, and how can a clinic obtain posters on screening? That's one of the questions being asked.
Okay, just send the information to, you can send me an email or contact the Ministry of Health or Health Promotion and Protection branch, and we can assist you with some of this information. Yes.
Okay, great. Now, colon cancer screening is a hot topic. So I will just, Dr. Mills pretty much addressed the question I was going to ask, and it's well said. So I'm going to read the question here.
Okay, great.
Will the ministry be making any submissions to insurance companies addressing the issue of screening as an indication for colonoscopy, and to move the age from 50 to 45 for those who cover it currently?
Yes, so what the ministry is planning through our National Committee on Non-Communicable Diseases, we are actually looking at doing a study to assess what is the situation and to make a recommendation generally for NCDs, which includes screening as well. So that's coming up for this year.
The study, sorry, just to clarify, the study is on what?
So the study will look at the state of our insurance offerings from our insurance companies. So what is being offered out there and how can we close the gap? So we're speaking about colorectal cancer screening. Yes. And so we have a team of our advisory committee that's going to be looking at that in the coming year.
Okay, very important.
And it's a critical component. Yes.
When people come for screening all the time, at least in the private sector, and when they find out that the insurance company doesn't cover it, they're gone. Right?
Exactly.
I mean, because they can't. And as Dr. Smith just alluded to, it's the wait time in the public system is very long.
And certainly as a general practitioner, my experience has been many persons come in and it's just not covered. And so you know, they have to have some diagnosis affixed to their visit or their recommendation. So screening is not covered. Plus our partners have also indicated they have had challenges around when they do their outreach screening, ensuring that the coverage is provided. And so this is something that we're looking generally globally from a holistic point of view, not just on screening, just to see what are some of the good strengths and also weaknesses around what is being provided here in Jamaica.
Okay, and that age limit is a thing because most of them that do cover it after 50.
Yes, and with our national screening standard, which speaks to 45, I think the Ministry of Health standard is something that can be part of that discussion, because the national, whatever is offered by the insurance should be aligned to the national standards.
Right.
And we do go below 50.
Okay, and the other point here is the Ministry of Health screening guidelines for colorectal cancer is quite useful, but in practice, how is it being applied?
Well, currently, we've done a bit of training. Last year, we did quite a bit of training with our clinicians. We're doing a pilot, and we have just completed the pilot, and we're in the process of wrapping up that evaluation. And so one of the things that we do routinely is actually do site assessments and audits and to get feedback. We're in the process also of updating again the guidelines, which we try and review every 3 years. And so that will also inform us. And I think if we think of guidelines, they're really working documents, live documents that are updated as soon as we get more updated evidence to check if they're still, the recommendations are still relevant. And one of the things that we continue to do is to promote the guidelines through this forum, Symposium. We took this opportunity again to ensure that we at least share the guidelines and, to bring awareness to the guidelines. And that's something that's an ongoing process that we have to continue doing. And so we welcome anyone who wants to invite us to, again, share these guidelines. And also I have shared a link in the chat to the website where you can download the guidelines. And also there are lots of other resource materials as well there that you can get.
Okay. Is it a possibility then, ideally, this might be a reach, but at least if in terms of the issue really is a national screening program, right? Because right now the people who are accessing colorectal cancer screening are those with insurance, more or less. Is there a possibility down the pipeline then for fit testing to be, you know, free?
Yes, so we are, well, I don't want to say much.
Or reduced?
But we are looking at how we can access fit tests or make it available. And as we go, we set the standards. We are working on, improving access within the public sector and also ensuring private sector as well. So persons have an option. So we're working to look at how we can get that cost or that test available in our mainstream program. But the first thing was really very important was to set the standard. So, and the standard would guide, the policy would guide what would be available and what would be prioritized as well.
There's a question here as to whether screening is being done in the public sector.
Yes, screening is being done in the public sector. And as I mentioned, we had a screening pilot where we were really assessing how well the screening was done and what are some of the gaps. So we do have some select sites in primary care where we have been doing a pilot, but we do, even prior to that, screening was being done. And now we have a organized national screening program around these 7 priority diseases, including colorectal cancer.
And this screening that we're referring to is by way of the fecal occult blood testing?
Yes, fecal blood testing, yes. And for those who are high risk, as a part of the pilot, we were also covering colonoscopy for them as well. And other tests as indicated in keeping with the guidelines. Okay.
I'm looking forward to next year. This time we'll be here again, and we're going to hear that fit testing is available for everybody.
Okay, well, speak it into being.
That's what I'm doing on this blessed Sunday morning.
And we are really happy to always be part of the program. It's our program as Jamaicans. Yes, not just Ministry of Health. We are the ones. Yes.
Okay, and Dr. Maturi, hope I got that name right. Sorry, is asking, once well established, how will the screening be conducted with the shortage of endoscopists nationwide?
Yes, so that's an area that we're really working to address. I know you have Dr. Nadine Williams on next. She's our lead, who is working on really improving the service, both within the public sector of priority. And I did hear your speakers before, and yes, there is a gap. In St. Thomas, in the public sector, is also being offered as well. So as well as KPH and UE, also in St. Thomas. So this is something that we're working on improving on, and then where we don't have that the service in the public sector, through the public-private partnership to improve access to this service. And of course, as mentioned, yes, the more we screen, the more you will have a higher demand for the service. And so there is a team looking at how we can improve on this and improve on the service available at the other end.
Okay.
Which is critical component.
Thank you, Dr. Davidson. And before I introduce Dr. Nadine Williams, I just want to, on that same point with regards to screening, since we have everybody here, I recently had a patient who was referred for upper endoscopy, and the indication for the upper endoscopy was blood in the stool, which the presumption was from the referral that was potentially melena. When actually speaking with the patient, there was no blood, she said, and it was a fecal occult blood test that was positive. So she came for an upper endoscopy after having a fecal occult blood test positive. So this education of our physicians too is going to be very important, because she ended up, of course, having a normal endoscopy and needed a colonoscopy, which then found the mass.
Yes.
Right.
Thank you for that.
Thank you. Yes. All right, so last but certainly not least, Dr. Nadine A. Williams. Dr. Williams is known to pretty much everybody here. But Dr. Williams is a consultant, internist, gastroenterologist, former head of internal medicine head of internal medicine and gastroenterology at KPH. She is now the Director of Health Services Planning and Integration, Ministry of Health and Wellness. She has numerous qualifications, including, and I'm putting all of them, graduate of the University of the West Indies, and she did her Masters of Public Health with a distinction in the UK. I thank you, Dr. Williams, for being here, and we look forward to your talk. Please go ahead. Not hearing you, Dr. Williams, you're muted.
Thank you so much. I was waiting to be unmuted. I am really very happy to see you, Dr. King Robinson.
Aww.
And to everybody here who is on the platform, I really want to say thank you to the Jamaica Cancer Society and all the persons who have managed to put this together again for another year. Very important, as everybody knows, I think, colorectal cancer and its prevention and its mitigation and the best outcomes is very, very dear to my heart. And so I'm very honored to be a part of this team today. And it is my hope and passion that coming together, all of us will contribute to a better outcome in the shortest time. So thank you so much for having invited me, and I will now share my screen. I'm having just a little challenge here, but I think that I will go along and start speaking because I'm having just one little challenge here. Let's go again. Let's try to share the screen once more. I am going to, not so sure why this is happening. Give me a second, please.
Hello, everyone. Dr. Williams will join you very shortly.
Sorry about that. While Dr. Williams tries to sort out, I think it's technical difficulties that are there. I would start off by at least her topic is going to be on disparities in colorectal cancer, the outcomes, insights, and interventions. She's just trying to get her screen shared. I'm not sure what this point. There's been a lot of chatter on the back end as well regarding the issues of screening, and just to address briefly the concern about the endoscopists. I will say that there are, well, we recently had a gastroenterologist come back from training, and so she is a new addition to the Kingston Public Hospital team, so that helps. There are other fellows in training overseas, as well as the gastroenterology fellowship that's now available at the University Hospital of the West Indies. And so the intention is to first essentially try to get a lot more people formally trained, so that those formally trained people will be able to help increase appropriate screening measures. Is Dr. Williams there, or she fell off?
No, she didn't. 1 second, please.
Thank you. I see you now. Sorry about the technical difficulties, guys. I think you need to unmute.
Thank you. Thank you so much. I really am sorry about that, but I could just go ahead. And I would want to say that with respect to disparities, I believe that one of the ways in which it was brought to the forefront was the disparity that was seen in African Americans and in the United States. And in 2007, as late as 2007, the Kaiser Permanente in Northern California noted within their database of persons who had registered, that there was a significant disparity between the colorectal cancer specific mortality between African Americans and whites, in as much as there were, the rate quoted was 54 per 100,000 persons, Blacks, compared to 33 per 100,000 whites. It's a significant disparity. This would have certainly been a reflection of what had been observed before, and this is as late as 2007. And so I would have chosen this as the opening slide because it really does reflect what would be perhaps an African-American gentleman in his pink tie. And the fact is that this would have been a profile reflected an increase in the incidence rate, colorectal cancer among African-Americans, a decrease in the survival rates, and overall poor outcomes in the African-American population. Next slide, please. Why would this have happened? You're seeing a disparity as a lot of persons, different ethnic origins, different shades of the rainbow here. And why would this have happened? This would have happened, is it because of a predisposition with respect to genetics? Is it that there was a difference in lifestyle activities and behaviors? Is it because of the use of tobacco? Or is it because of, as has been said several times, a minimization of access due to poor, inadequate insurance coverage, for example? or less access to earlier diagnostic capacity, or less access to treatment. So there are many different reasons why this could have happened, and who is to know? Certainly a lot of research would have been generated and to determine what exactly are we seeing with respect to disparities in health. And then opportunities to study interventions which would help to mitigate these disparities if they were noted. Next slide, please. And so disparity really refers to, in a purest sense of the word, it refers to just a difference in between groups. And yet the word disparity suggests that there is a meaningful difference in outcomes where it is concerned. But there are indeed nuances as it relates to this word disparities. Next slide, please. And so we'll speak about inequality. Inequality suggests that there has been not just a difference in the group. So you remember in Animal Farm, all are created equal, but some are more equal than others. There are so many different reasons between age and gender and race, ethnicity, social behavior, socioeconomic status, religion, choice of where we access health, or educational level, and choice of who our insurance providers are but some of our differences. And that could just be inherently a difference. The fact is that there is also the concept of inequity. Next slide, please. Next slide. And so inequity suggests that there is something, well, just before we went to the next slide. So inequality suggests that there is a difference, and yet the fact that there are risk factors present, the fact that there are risk factors present within the context of these differences is the reason why we have to speak about disparities. Next slide. And you could move on to the next slide. Sorry, I don't have control over my slides. And so the term inequity, if you could go back to this one, you go back to inequity, 2 slides back. The term inequity really does suggest that there is some amount of deviation from what we would call horizontal equity, which is that whenever the individuals that have the same needs should be treated equally. Next slide. But the term inequity also has the connotation that there is unfairness and injustice. Next slide, please. Health inequalities suggest that there is an avoidable difference in people's health across the population and between the specific groups. So not only are there differences, but when we speak about health inequality, there's a suggestion that to some extent, these differences, if they make meaningful differences in the outcomes, or have some amount of avoidable connotation to them. Next. And so disparity, we said, is a noticeable, significant, and often unfair difference between persons or things. Next. And so next slide, please. So health disparities, we've gone through a lot of nuances. Health disparities really speaks to a noticeable and significant and often unfair difference between groups. And it speaks to the fact that there is this disparity can occur anywhere in the continuum of health. And so the continuum of health looks at prevention, early diagnosis, treatment, and post-treatment care. If care can be applied at any point in this continuum, it means if there is a significant difference between the groups along this continuum of care, it means that outcomes can be different. It's important for us to consider, because a lot of times our consideration for differences really just speaks to treatment, and is treatment available, and do persons have enough funds? And yet this might not be the only aspect of the differences and disparities. Next slide, please. Thank you so much. So we have to recognize that there are some barriers to care. And so the barriers to care are multiple, and we'll speak about that later. But as we speak about barriers to care, they may interfere with the outcomes. Next. So the outcomes, we usually speak about outcomes as survival rates. That is the performance measure. That is the measure that is often used, which is the element that is used to say, how is this country doing? How is this program doing? The country is as good as the survival rates or not. And I would have quoted that, but go next slide, please. Next. And so if we look at survival rates, for example, the last slide would have given the summary rates of colon survival rates, which if you look at the SER stage combined, you'll see that in the US, they quoted, I believe this was in 2017, an overall combined rate of 63%, and in the rectum, 68%. And this would have been dependent upon the stages. And so the localized stage, if it's colon, if it were that the cancer was just localized, overall the rates, the 5-year survival rates is about 91%, fairly comparable with rectal rates at that time. And so they were quoting survival rates as their measure of success. Next. Next, please. Thank you so much. And you would have heard Dr. Smith refer to what our local experience, because Dr. Plummer's published article in 2016 showed that there was a survival rate, 5-year survival rate of only 33%. So you could see that there was a significant difference between what our outcomes were and what those outcomes would have been. And yet what I wanted to say to us is that the outcomes is not just a measure of the survival rates that we should be looking at, because yes, survival rates are very important, but also are on the way to surviving or not surviving, there are some intrinsic experiences. And so the personal experience of care, the quality of life scores that are usually generated if such scoring tools are applied, functioning capacity, as well as screening rates. You'd have heard a lot about screening. And certainly when we think about process indicators or process performance measures, screening rates would have been such one of those parameters that would be an important consideration to determine just how our healthcare system is doing as it relates to colorectal cancer. Next. So I would have shown you the continuum of care, and it is important to note for us to consider there may be disparities, there may be inequalities, but what can we do at the different points which may increase our overall outcomes if we consider our outcomes to be, yes, survival rates, but in addition to survival rates, more than a survival rates, we have to consider what would we be able to do? And so, yes, there are inherent risk factors which we can do nothing about. Genetic, your age, your gender, can't do anything about those. But we do recognize that it allows us to pay attention. So example, we would have identified the fact that more young persons are actually being diagnosed with colorectal cancer. The socioeconomic status is a big one. It is often thought that persons who are not as well off do far worse because they can't access care and they can't access, sophisticated care, etc. But it is much more than that because even, there is exposure to food and people make wrong choices many times, even though they might be exposed to positive environments. And so the use of excessive red meat, preserved foods, processed foods, and insufficient fiber, fresh fruit and vegetables are certainly some of the factors which will contribute to the outcomes. Lifestyle choices, so tobacco use, sedentary lifestyles, morbid obesity, poor dietary choices, as I had said before, would actually weigh heavily on a negative outcome. Dr. Davidson would have referred to the importance of health promotion and education, and this too is an important point, which is cross-cutting across, factors which are for which you can do nothing about, to those which are related to exposure and access to healthy lifestyle and healthy food, for example, as well as lifestyle choices, but it also has to do with an understanding of what the diagnostics are available. It also has to do with an understanding of what the symptomatology is available. So health promotion and education spans the whole gamut. Dr. King Robinson would have made mention of the importance of sensitizing our healthcare workers to exactly how persons present and what their symptomatologies and how they should be treated. So health promotion and education is highlighted in red because irrespective of where in the continuum we are, we have to ensure that persons, both lay as well as learned, are educated with respect to this matter. We would have already spoken a lot about screening and then the interventions as it relates to treatment, both diagnosis and treatment, surgery, radiotherapy, chemotherapy, or targeted treatment being interventions that have to be applied or ought to be applied with adequate timing, adequacy of meaning comprehensive and quality care, as well as looking at the barriers as it relates to access. And cost is one such, but it's certainly not the only thing. Next. So these were the points that I had made reference to. And with respect to the barriers to care that I had made mention of, we spoke about lack of insurance or lack of the appropriate insurance, because you may have insurance, but the insurance company may not cover what we want it to cover. Poor patient-provider communication, very important. The cost of the service that we're trying to get, a lack of trust. We haven't mentioned that so far, but I will just reiterate again, and the differential in terms of perception of risk. Next. Why would these be important? It would be important because for example, perception of risk. Young persons, they often believe they're invincible. They don't need to be screened. They don't need to go to hospital. A lot of times men who have generally poor health-seeking behaviors do not readily go and access care. And so, yes, gender is an important thing. A lack of trust. Many times, in fact, in the US, there are many studies which show that there is a significant difference between the access to care in persons who are in America, or if they've even been migrants, who have been there for more than 15 years, compared to persons who have been there recently and not really able to access or trust the system. So it is important to know that overall, what we would want to know from a colorectal cancer program is that there are improved outcomes, and the outcomes we had said, survival rates, quality of life, personal experience when being treated, as well as post-treatment functional rates, by diminishing the barriers which threaten optimal outcomes, increasing access to elements which will facilitate optimal outcomes. Next. And so next. Just to ask ourselves a few questions. How can we create an enabling environment? So the primordial prevention, yes, next, would suggest that we are creating an enabling environment. So not only are we knowing that, for example, let's just say fresh fruits and vegetables will help to reduce the overall incidence of colorectal cancer, but we would ensure that we have increased access to fresh fruits and vegetables, such as ensuring that this is what is in our schools, for example, as opposed to sugary drinks and processed foods. Facilitating a lifestyle that is characterized by exercise, meaning you're creating a sidewalk so persons can actually access, and sports centers, persons can have places to exercise. Allowing for less preserved foods to be available to our population, and reducing access to tobacco and tobacco products. Essentially, this would require an all-of-government approach and certainly policy support. Next. Next, please. And so how can we help persons to make better choices? Helping persons to make better choices suggests that more in primary prevention. It's related to more primary prevention, where, and again, health promotion and education is going to weigh very heavily. So this means increasing awareness of risk factors, increasing awareness of what is it that is better for us to eat, And while we ensure that there's access to healthy foods, making sure that persons are aware. So for example, there is a healthy options in some restaurants right now in Jamaica. How many persons are aware, even though it would have been said several times? Provision of healthy menus. And so the intention is that with respect to primary prevention, we would be able to choose better and that behavior change will be facilitated. This, however, is threatened by the concept of, like a health education inequality or communication inequity, or any of those words that would suggest that the language we are using is not received by everyone in the same way. And it's very, very important that we mitigate the risk of that kind of inequality, that kind of difference in communication by ensuring that we use strategies so that all members of our population are equally receiving the message. So in the same way, we had the video that Dr. Davidson had promoted. There is a number of persons in the population who would be able to get it much more readily. Next. Next, please. How can we increase earlier detection? And so early detection we just went through a whole gamut, the whole conversation about screening, but it is also important to know that detection also has to do with early recognition for persons who are symptomatic. A lot of persons do not recognize their symptoms. And so between screening and early diagnosis, it is important not only to have access to screening, a programmatic screening, for example, but also to have access to the diagnostics, which is going to allow for us to have early diagnosis, allow increased quality of the diagnosis, as well as a capacity to follow on. And you'd have all brought up the whole matter of ensuring that not only should we have the screening as a first step, but with positive FOBTs, fit tests, etc., that we're able to follow on with colonoscopy. Next. Next, please. Next. And so, yes, it is true that 45 is a new 50, because last year we would have noted in May 2022, the American Cancer Society themselves had actually changed the guidelines to say that no longer is 50 the age that is being recommended for this screening to be applied, but actually 45. What we see here is the impact of population screening, where there's been a decline in the incidence and deaths, both in the African-American population as well as in the Caucasian population in the United States. But you could see that there is a narrowing of the gap in between, and there's a significant decline in both incidence and deaths. Next. Next, please. How can we diagnose colorectal cancer earlier? We had spoken about that. So how can we increase diagnostic accuracy? Dr. Smith was quite right when he made reference to the fact that there is disparity between the quality of services that are being offered. It is important for us to monitor the services and for persons themselves to know what they're capable of doing. And so adenoma detection rates from colonoscopists, audits, quality assurance exercises are all very, very important, so that these are strategies which will allow for us to increase diagnostic accuracy and to allow for us to be able to access the appropriate service. Next. Next, please. How do we improve outcomes as it relates to treatment outcomes? Well, so we would have had a slide before that spoke to, while we're navigating the treatment, how do we ensure that despite inequalities, we ensure that there is an improved, if you could go to the slide before, that there is improved outcome. The fact is that we want to ensure that there is increased access. We want to make sure that there is increased access of drugs, access to radiotherapy, access to chemotherapy, etc. We want to make sure that there is that. And so even after treatment, that we want to make sure that there is access to the support that is required even after treatment, and to ensure that persons have their post-treatment surveillance. So many times persons having had colon cancer, they are happy, they are cancer-free, but they forget that they were once at risk and think that they're no longer at risk. It's important for persons to assume the risk reduction lifestyle that we had spoken to them about before, and that they actually do their surveillance colonoscopies as is necessary. Next. Next. Thank you. How can the quality of life of outcomes, if you could go back, you're running ahead of me a little bit. When cure is not possible. So this speaks to palliative care. So while we're speaking about colorectal cancer, we did speak about metastatic disease, and whereas metastatectomies are possible, and whereas targeted therapy is possible for persons with metastatic disease, it is also important to know that sometimes cure is not possible, and yet it is important consideration. So as we look at the inclusion of palliative care in our primary care model as it is renewed, it is important that psychosocial support, which should be available throughout the gamut, palliative care and other supports like nutritional support, like access to informed support systems. So a lot of times family and friends, they don't know, they don't have an idea because they haven't been spoken to adequately. It is important. It is also important to have pastoral care to be applied as is acceptable. Next. Next, please. Next. And so there are several factors. Yes, we would have spoken about these already to say that not only are there cost barriers, but also there is inequality as it relates to support, and inequality as it relates to psychosocial support and education. Next. Next, please. So this if you could go back one, please. As it relates to primary care, the fact is that I had brought up the matter of trust. Studies have shown, there are enough studies to show that there is improved outcomes when persons have access to their continued access to the same primary care provider. Primary care provider being the central person who is going to help to administer care. And so if it is that there is a disparity between the person who is advising them and giving them treatment and so on, the general outcome tends to be not as good. Why is that important? The access to information or access to interpretation of information. Sometimes that person is the access to the drugs that they need. They're given a prescription and they have to sort of source it from all over. And their usual primary care provider is a stability and a stable force where that is concerned. And they may provide expedited access as well. So it is important to know that sometimes the disparities that occur is because of the differences, the variation in the primary care provider. Next. Next, please. One, next, yes. And so we spoke about screening, and I don't think we need to go over that. Next. With respect to what we have seen, it is important, I believe, that the young adults should be targeted, and targeted in the way that suggests that the educational messaging should utilize young adults very much, because as was mentioned, 2021 JAMA study shows that colorectal cancer is actually projected to be the leading cause of cancer deaths for those 20 to 49. And that is a very, very troubling projection, because it therefore means that this should look at the reduction in the screening rates, because we tend to want to screen 10 years before the usual start to the onset of cancer. Next. Next, please. And yet there is still concern for colorectal cancer in the Black population. It is important to note that policy would have been applied in the United States, and this was just published in February 2023. Legislation was just passed to increase access to screening in New York and New Jersey. And what does this mean? This means that they have passed the laws to allow for screening to be supported across the board, not just at 50 years anymore, but at 45 years. So they've reduced the age, which is what Dr. Mills was speaking to, and a number of questions would have come out. But not only that, but that there is no pay out of pocket for persons who, having screened and having had to move to a colonoscopy, that there's no out of pocket pay, right? And so this actually is an extremely important example of how policy is supposed to help to improve access. Now, can this be transferred to our population? This is something that Dr. Davidson has said, that there's going to be further discussion, and a move to push this forward so that we can actually have increased access for persons who are insured to screening at a younger age. Next, please. Next. And so this came out of a fight, an advocacy fight. So here it is that we have, we had spoken about screening, but it is important to know that there are different factors which are going to increase your screening uptake. It is going to increase when persons have a life partner with whom they're living. So you have support to say, yes, you should go ahead and do your screening. It is going to improve when there's higher educational levels. It is going to increase when there is a usual source of care, and we spoke about that earlier, and a personal, or if there's a personal history of cancer. Engagement in preventive health behaviors is also very, very important, and that's well established. I'm sorry that there is inclusion of stuff that shouldn't be there, but what it is saying is that persons who usually are good in their health-seeking behavior will actually have a greater likelihood of increasing uptake to colorectal cancer screening. Next. And so our goals in colorectal cancer screening, we have spoken about the disparities that are caused by socioeconomic factors, the communication inequality. I just want to read this. Communication inequality is defined as the differences between social classes in the generation, manipulation and distribution of information at the group level, and differences in access to and ability to take advantage of that information at the individual level. Next, please. And so what is happening is that the very people who need it are not the ones who are getting it. You know, we have spoken about the interventions that can occur along the continuum, and the fact that the truth is that money doesn't always guarantee the best outcome, because if there's communication inequality, it doesn't matter how much money you have if you can't understand what is being said. Next. So what would have that slide before it says is an example of how the fact that you have money does not necessarily guarantee the best outcome. If, for example, there's private care versus you're in a tertiary level institution, if it is that what needs to be communicated is not happening because it's a middle level sort of doctor who doesn't necessarily understand what the different symptomatology mean or how it is that the different elements of care should be transferred, then it is going to be different from if you have a consultant who has the in-depth knowledge and it's translating that information. That's an example of how one's experience may actually it might appear to be equal, but it's actually not equal, and the outcomes, be it survival outcomes or experience outcomes, may actually be different. So as we're winding up, in a sense, health disparities do exist in colorectal cancer care. Bridging the divide between actual outcomes and potential outcomes around the many different components of outcomes we spoke about is going to be when we can actually put all the interventions together across the continuum. Next, please. And so this is my summary slide, which says, well, you just went away from my summary slide, but essentially it just spoke to all the different areas as it relates to primordial prevention. What would I want us to take away? We need to provide an enabling environment. With respect to primary prevention, we need to ensure that in our health education, in our health promotion and education, that we're targeting the young. And with respect to our secondary prevention, yes, that we embark on a very robust programmatic screening, avoiding the disparities and availing diagnostics. That with respect to our treatment, we ensure that we emphasize and communicate, and I didn't have to reiterate the multidisciplinary team, which was already discussed, that we provide psychosocial support, and even if it's palliative care, that we ensure that there is an intervention, as it is, we're going to be having that intervention to be included in primary care, which the primary care renewal model, which is now being developed, and that we across the continuum ensure that health education is important. I apologize for the hiccup earlier on, but I hope that we understand that there is in fact disparity, that we do everything that we can to bridge those divides so we can optimize the outcome. Thank you so much for allowing me to participate today. Over.
Thank you very much, Dr. Williams. That was a great end to an excellent symposium. A Sunday morning well spent. There are a few questions that I'm going to bring up. That's in the chat. Is the MOH planning to support training and equipment to improve access to colonoscopy for patients in the rural areas?
Did you ask what is the plan?
They're asking, the question here is asking whether the ministry is planning to support training and equipment to improve access to colonoscopy for patients in the rural areas.
I would say certainly as it relates to our cancer plan, there is a plan to do that over the ensuing years. And so that is certainly going to require training and improving access to equipment. So yes.
Okay. And Dr. Wright has said, thank you for this very interesting symposium. The question is there consensus? This one might not be for you, Dr. Williams, sorry. Is there consensus in the medical fraternity about the sequence of the treatment as put forward by Dr. Kern Pemberton?
So I'm not sure, is it myself that has been?
I think this is more, well, potentially, I think she wants to know from the ministry if there is consensus as to the treatment that Pemberton was referring to, the radiotherapy with the rectal cancer.
Right. So I think that's a very good question, and I'm glad Dr. Lowe is on, because we have a colorectal cancer working group. I'm sorry, that's a Freudian slip. It's actually a cancer working group that looks at the treatment element, because they're certainly out of the preventive group would have rolled out the screening guidelines Dr. Davidson pointed to, shared with you. But as it relates to treatment, that is being worked on, and the definitive guidelines will be made available.
Okay. Well, that is it for the questions here. And thank you very much, Dr. Williams, for joining us. And thanks again to Jamaican Cancer Society for putting on this amazing symposium. At this time, we are gonna have, we can't do this without our sponsors. We're going to have a presentation briefly by Rush Farmer. All right. Thank you very much. Thank you all for coming. At our peak, I think we had about 180 participants, and that therefore signifies that there's, you know, a lot of us now that have the knowledge to be able to go forth and spread the word to our patients. A lot of key points came out today regarding colon cancer, and more importantly, it's screening in order to prevent it. And we are looking forward to the day when we won't have to talk as much about colon cancer, because it will be so uncommon as we strive to prevent it happening. This time, I'm going to invite Ms. Dion Thomas to give the vote of thanks. And again, I just want to thank you guys for coming. Ms. Thomas.
I'm not sure why my video is not coming on. Okay, I'll just get into it. Good afternoon, everyone.
Afternoon.
I am filling in for Ms. Julianne Brown, who is unable to attend. She's the Fundraising and Public Relations Officer of the Jamaica Cancer Society, and I'll be giving the vote of thanks. On behalf of the Board of Directors, management, and staff, volunteers of the Jamaica Cancer Society, we'd like to express our heartfelt gratitude to all our presenters for taking the time out of their very busy schedules to prepare and present on this excellent topic today. Without your contribution, this conference would not be possible. To our moderator, Dr. King Robinson, thank you for assisting with the smooth flow of the program today. To Dr. Mike Mills and Mrs. Stacy and Daly Surton, thank you for playing an integral role in this conference today. To our IT team, David Miguel and company, without you, our webinar would not be possible today. To our sponsors, AA Laqui, Apex Radiology, Rush Pharma, Basic Pharmaceuticals, and Abbott Nutrition, thank you for your continued support. The Society looks forward to partnering with you in future events. And last but not least, to the medical fraternity, thank you for your support. Please note, your CME credits will be sent out electronically within a week. And also, save the date for our next medical conference, which will be our Dr. St. Joseph Elmo Hall lecture on cervical cancer. That will be held on April 30. Again, the Society, thank you for your support. Have a great afternoon.
Thank you, everybody. Have a good day. Bye-bye.